Hello everyone, welcome back to part 2 of Pathology 999, the end game. So this is part 2 of the video and we'll start from point number 41. So if you haven't seen prior episode, please go back and watch from Dr. RMD YouTube channel, end game playlist. So going to liver cirrhosis. What is liver cirrhosis? There are two main histological features which are characterized by liver cirrhosis. One is fibrous septa. See, these are the liver cells, these are the portal tracts, okay, these are the liver lobules. So you can see collagen and fibrosis here, no? So this is known as fibrous septa, which are bridging between the portal tracts, okay? And along with that, there are regenerative nodules. So these two are characteristics of cirrhosis. So if in histology, if they ask, histology of liver cirrhosis is characterized by which two changes? Fibrous septa and regenerative nodules. Now, these regenerative nodules can be of two patterns. One is micronodular and one more is macronodular. And very important, alcoholism, alcoholic liver disease is characterized by micronodular liver cirrhosis. Okay. So what is the reason for this cirrhosis? So anytime there is liver injury, either due to alcohol or viral hepatitis or maybe metabolic liver disease, which is now known as metabolic associated liver disease, which is also known as fatty liver disease. Okay. So in this, what happens is because of this damage, there is activation of a stellate cell. Remember which cell? Star-like cell. Can you see this? This is star-like. Okay. So this stellate cell is activated, which will cause deposition of collagen. Okay. So there is fibrosis, septa formation, and then there is regenerative nodules. Now we call this as cirrhosis. So hepatitis is not cirrhosis. When chronic inflammation causes fibrous septa and regenerative nodules, that is called cirrhosis. Okay. So what are why cirrhosis is so bad? Because once cirrhosis happens, so these hepatic sinusoids, they have increased pressure. So this is known as portal hypertension. So these liver sinusoids, they have increased blood flow, blood pressure inside it. So we call it as portal hypertension. Definition is more than 12 mm Hg of pressure in the portal tract. Okay. Now, this causes splenomegaly, okay, because this is connected to spleen here. So this causes splenomegaly, and then because of this, there is opening of portosystemic shunt causing esophageal varices. There is also other portosystemic shunts around the umbilicus that causes caput medusae, and then there is fluid buildup in the abdomen that is called ascites. So these are the complications of portal hypertension. And if you ask me the triad of portal hypertension, it is ascites, splenomegaly, and varices or portosystemic shunt. Okay, portosystemic shunt can be caput medusae or esophageal varices or rectal hemorrhoids. So next is along with this, what will happen is liver synthetic function. Liver synthetic function is measured by two things, very important. One is albumin and second is PT-INR. Okay, INR levels, that is ability of the liver to synthesize coagulation factors. Okay, so if PT-INR is deranged, there will be coagulopathy. You can see gum bleed, skin bruising and all. And if there is low albumin, then it will cause fluid retention in the form of ascites and all. Okay, so these are the two hallmark features of synthetic failure of liver. Okay, and chronic inflammation will finally lead to increased risk of hepatocellular carcinoma. Okay, so these are the complications. This is portal hypertension features. Okay, so what are the other things that you should know? What is the treatment for ascites mainly? Okay, management of ascites is, one is salt restriction and second is diuretic. So we give furosemide. Okay, furosemide or torsemide, this diuretics we give. Okay, next, if there is liver cirrhosis, you should also screen for hepatocellular carcinoma with ultrasound and AFP. Okay, the AFP is nothing but alpha fetoprotein. Remember, alpha fetoprotein, where did you study? Yes, in part 1 you studied alpha fetoprotein. You studied under tumor markers. In that you had two categories for alpha fetoprotein. Alpha, remember, alpha is equal to baby. So it was, one was for yolk sac tumor, okay, and other was for hepatocellular carcinoma. Okay, so that we are going to screen once there is cirrhosis. Then if there is portal hypertension which cannot be addressed with medical management, then you go for TIPS. What is TIPS? TIPS is transjugular, okay, transjugular intrahepatic portosystemic shunt. Okay, so basically what you do is you bypass portal vein, which is the cause for portal hypertension, and directly go into the inferior vena cava. Okay, so that is called TIPS, into the hepatic vein. Okay, that in turn joins into inferior vena cava. So Kupffer cell hyperplasia. Now what is Kupffer cell? Kupffer cell is the macrophage present in the liver. Okay, so this Kupffer cell hyperplasia in turn secretes TGF beta, and this TGF beta in turn activates this stellate cell, and stellate cell deposits collagen, and this collagen is the reason for this fibrous septa. Okay, so this is how the entire process of fibrosis takes place. Okay, so stellate is for star, which produces collagen. Okay, portal hypertension I have told you, and then micro is for many, that is for alcohol. Okay, so let's solve the questions. So which are the two key factors of defining cirrhosis? One is fibrous septa or fibrosis, and second is regenerative nodules. If you have taken PDF or if you have printed it, please write down these things, or else you won't understand this, you won't remember this. Stellate cell activation causes deposition of collagen. Which nodular cirrhosis seen in alcoholic? I said alcohol is many, M is micro. Okay, micronodular. Post hepatitis you see macronodular. Okay, and then which fibrosis is seen in NASH? I think it was missed out here. Okay, see here, NASH is non-alcoholic steatohepatitis. Okay, see this thing. So here what happens is fatty liver, when it progresses to hepatitis, then it is called as NASH. Okay, so this is chicken wire fibrosis. That is a pattern you see on histology. So which type of fibrosis? Chicken wire fibrosis. Okay, next, which cell hyperplasia occurs in cirrhosis? Kupffer. Kupffer cells are the macrophages of liver. Hyperestrogenemia leads to spider nevis or spider angioma. Okay, I think I have shown you spider angioma. Yes, it is here. Okay, next, portal hypertension. What is the what happens in portal hypertension? What is the triad of portal hypertension? Ascites plus splenomegaly plus portosystemic shunt. It can be caput medusae, it can be gastric varices. Okay, screen for HCC every 6 months. Okay, with the AFP, that is tumor marker, and ultrasound. Okay, so this is all about cirrhosis that you need to know. Repeated questions are being asked. Okay, because of low albumin you have actually ascites and all. Okay, hypoproteinemia, everything occurs because of liver's decreased synthetic capacity. So next we'll go to one more important topic, that is myocardial infarction. Okay, next topic is myocardial infarction. So basically what is important from pathologist perspective is the timing of myocardial infarction, what histological changes occur. That's why this everything is summarized in a single slide only. In the first 24 hours, there is early coagulative necrosis. I told you coagulative necrosis, MI is one of the most important examples. So there are wavy fibers because of coagulative necrosis, and during these 24 hours, erythema is very common. Okay, so the most common cause of early death in MI is because of erythema secondary to myocardial infarction. Now, after 1 to 3 days, we have neutrophils. You can see neutrophils coming over here, and they'll invade the myocardium. Okay, so it causes neutrophilic infiltration, which sets the inflammation phase. Now, after 3 to 7 days, now what happens is the macrophages come, lymphocytes come. This is same as acute inflammation process, which I have explained in topic number 1. Okay, acute inflammation. So now what happens is there will be smoothing of the heart dead cells. Okay, wherever there will be smoothing, and this is the reason why there can be papillary muscle. Can you see this is a papillary muscle rupture, or there can be wall rupture, ventricular wall rupture also leading to cardiac tamponade. Okay, there can be fluid buildup in the blood buildup in the leak into the pericardial cavity. Okay, so papillary muscle rupture and free wall rupture occur maximum between 3 to 7 days, and then healing starts slowly. Okay, there is granulation tissue, angiogenesis, fibrosis. Okay, so remember what is granulation tissue? Granulation tissue is nothing but angiogenesis with fibrosis. I had told this in topic number 3, that is chronic inflammation. Now then later on what happens is dense scar formation takes place, and then that time there is risk of aneurysm. So very important MCQ comes, that is they will give all these complications and they'll say which one of this is not an acute complication which occurs later on. That is nothing but aneurysm. Okay. So there are some biomarkers, and most important out of this is troponin T, and which increases by 3 to 4 hours, initial 3 to 4 hours. So we do trop T or trop I levels. Okay. So these are the complications which I have already explained. There are some extra things that you need to know. One is contraction band. What is this contraction band? See, that image is given. Okay, so it is basically eosinophilic, that is pink colored. What happens is when there is suppose this is the heart and this area has undergone infarction, when there is reperfusion, so blood comes again back during reperfusion. Okay, so what happens is that with this blood there comes calcium. So calcium enters these dead cells, and because of that there will be hypercontractility, that is hypercontractility of sarcomeres. Okay, sarcomeres present in the muscles contract extremely, that leads to death of the cells. that death results in contraction band. Okay, so contraction band is nothing but hypercontracted sarcomeres because of increased calcium during reperfusion. Okay, second is Dressler syndrome. What is Dressler syndrome? Important is Dressler syndrome occurs 2 to 8 weeks after MI. Okay, after MI 2 to 8 weeks, that is up to 3 months duration. Okay, sorry, 2 months. Now, why Dressler syndrome occurs? What is it? It is antibodies which are directed against the pericardium and the heart. That is because when necrotic tissue is there, no, the myocardial infarction occurs. Some of the necrotic tissue will be exposed to the blood, so antibodies development takes place. Okay, so these antibodies cause this autoimmune pericarditis, that is called Dressler syndrome. Next, reperfusion, I have already told you. Now, what are these ACE inhibitors and what is the role of ACE inhibitors in myocardial infarction, post myocardial infarction? Now, what happens is when there is myocardial injury, what will heart try to do? It will try to remodel. Okay, what is remodeling? As the word says, heart will try to accommodate its shape so as to preserve its function in pumping. Okay. For short term it is beneficial, but what happens during long term is it will change the shape of the heart. It will cause some structural changes within the heart. Septa gets thickened. Some other changes also happen. Okay, so this leads to heart failure. Okay, and which is the main mechanism which leads to this cardiac remodeling? That is RAS mechanism. Okay, renin angiotensin mechanism. Okay, that's why angiotensin inhibitors, that is ACE inhibitors. Okay, ACE is nothing but angiotensin converting enzyme inhibitors. Okay, so that blocks this RAS mechanism and that prevents heart failure. That's why ACE inhibitors prevent remodeling. There shouldn't be any doubt regarding this concept. Okay, so let's go and answer the questions. Neutrophilic infiltration occurs on which day? First to third day. Okay, papillary muscle ruptures occurs in third phase, that is during macrophage activation phase, that is between 3 to 7 days. What is the most common cause of early death? Early death is arrhythmia. Okay, arrhythmia. But troponin rises in first 3 to 4 hours. Contraction bands are seen in reperfusion injury. Okay, reperfusion injury. And then which syndrome is related to autoimmune pericarditis? Dressler syndrome. Okay, and what prevents remodeling? ACE inhibitors prevent remodeling. And monitor for DASH during post-MI, monitor for heart failure, because our pump is lost, no? That's why they can go into cardiogenic shock and all. Okay, so next topic will be malignancy again, ovarian carcinoma. One more very high yielding topic from pathology as well as OBG is ovarian carcinoma. Basically, there is something called as fimbrial epithelium theory. That is, ovarian carcinoma doesn't arise from the ovary, but actually it is from the fimbria of the fallopian tube. So these cells detach and they go on the ovary and settle and they cause ovarian cancer. Okay, that is the reason for fimbrial epithelium theory, and there is also one more applied aspect of it which I will be telling later on. So there are basically four histological types of ovarian cancer. One is serous carcinoma, mucinous, endometrioid and clear cell, out of which clear cell is very bad because it is chemoresistant. High grade serous carcinoma has P53 and BRCA link. Okay, so endometrial carcinoma had which mutation? P10 mutation. Remember, PTEN, and EN stands for endometrium. Similarly here it was P53. Where was one more BRCA you had studied? It was in breast carcinoma. Okay, breast CA, especially triple negative. Okay, triple negative is ER negative, PR negative, HER2 negative. That was associated with BRCA mutation. And BRCA mutation is which type of DNA repair defect? It is homologous repair of DNA defect. Okay, so BRCA is a risk factor. Along with that, nulliparity. Why? Because in nulliparity there is unopposed estrogen action. There is no progesterone action. So progesterone is protective for ovarian carcinoma, whereas high estrogen is causative of like ovarian carcinoma. So you do ultrasound, and ultrasound you will find adnexal mass, that is ovarian mass, and then you do imaging with the transvaginal ultrasound or with CT. Okay, and then what is the treatment that you do? One is you do cytoreductive surgery. What is cytoreductive? Cytoreductive means debulking surgery, which means you remove tumor as much as possible so that chemo can act after that. Okay, so you send for biopsy and you see for what is the surgical staging of the tumor. And chemo, what you will give? You will give platinum chemo, that is carboplatin. Okay, sorry, what is the platinum chemo that you will give? Carboplatin. And along with carboplatin you give paclitaxel. Paclitaxel is a taxane group of drug. Okay, in anti-cancer drug we'll study that. Okay, so we use that and along with that we'll use CA125. Remember, CA125 in tumor markers we had studied, no? CA125 was for ovarian CA. So CA125 is for monitoring but not for screening. Okay, remember this. Imaging we have already discussed. OCP is protective. Why? Because progesterone in that it is protective. Okay, progestin in that is protective. Now, what is Meeks syndrome? Meeks syndrome is specific for, not for ovarian carcinoma, it is for ovarian fibroma. Okay, so it is for ovarian fibroma. So when ovarian fibroma is there, it will irritate the peritoneum, causing ascites, and there will be lymphatic spread also, causing right-sided pleural effusion. Okay, so this is known as Meeks syndrome. Now, suppose this is not caused by ovarian fibroma. Let's say it is caused by ovarian CA, or it is caused by a teratoma. Then it is known as pseudo Meeks syndrome. Okay, pseudo Meeks. So remember, Meeks syndrome is actually benign, but there will be associated ascites and pleural effusion. What is the histological part? Basically, serous structure. It is, since it is a papillary serous type of carcinoma, so we'll have psammoma bodies. Remember, where else we had psammoma? Yes, very good. In thyroid papillary carcinoma also we had psammoma bodies. Also in dystrophic calcification also we had psammoma bodies. Okay, let's solve questions. High grade serous, which mutation we have? P53 mutation, and associated with which other DNA repair defect? That is BRCA. What is the origin? Fimbrial epithelial theory. Okay, fimbrial epithelial original theory. Okay, marker which is used for monitoring of ovarian carcinoma is CA125. What is protective? OCP use is protective. And what is the treatment? Very important. We do bilateral salpingo-oophorectomy, especially in BRCA positive cases. That is because I told you, there is fimbrial origin of tumor. So that's why not only ovary, we'll have to remove this fallopian tube also, so that there won't be any fimbrial cells to cause further more recurrences. Psammoma bodies are seen in serous type of carcinoma. What carcinoma resists chemo? Clear cell. I told this, clear cell is a dangerous type. Meeks syndrome is seen in ovarian fibroma. Pseudo-Meeks is seen in ovarian carcinoma. Okay. Which mutation? High grade serous carcinoma, again P53 mutation. If BRCA carrier, we do prophylactic bilateral salpingo-oophorectomy. Okay. Sorry, this whatever is there, this is for ovarian CA. Treatment is actually carboplatin. First is cytoreductive surgery. Cytoreductive surgery followed by carboplatin plus paclitaxel. Carboplatin plus paclitaxel. So here in BRCA mutations, we do bilateral salpingo-oophorectomy. Okay. What counseling essential? Genetic counseling. Why? Because BRCA mutations is involved and P53 is also involved. So specifically for BRCA, we'll have to do, because if anyone is a BRCA carrier, then we'll have to do bilateral prophylactic. Means before the symptoms appear only, we will have to do prophylactic this one. Okay, salpingo-oophorectomy. So next one is, so pancreatic adenocarcinoma, a very aggressive tumor. Okay, so what are the risk factors? Mainly smoking and recurrent chronic pancreatitis is a risk factor for this one. Okay, so there are genetic mutations also, like KRAS. Where have you heard KRAS? Yes, very good, in colorectal carcinoma. P16 and P53. These three mutations are involved. Okay, KRAS, P16, P53. Now they cause changes in DNA, and then there will be tumor mass. Okay. Now what will happen is, the most common location, okay, where is this tumor? See here, where is this? It is in the pancreas head, right? So most common location is the head of pancreas. Because it is at the head of pancreas, this head of pancreas, there is one more opening, that is opening of common bile duct. That's why there will be gallbladder, there will be obstruction, and there will be enlargement of gallbladder also. And since this is not an inflammatory process, this is a it is not a painful process. That's why there will be painless. Okay, painless enlargement of gallbladder. Okay, and there will be jaundice because of obstruction of common bile duct. This metastasis also occurs very early. Okay, and it can go to liver, lungs, and stomach. Okay, so wherever there is lymphatic route, it will go through that. Okay. Next, what are the clinical presentation? One is painless jaundice, as I told. Second is Trousseau sign. What is Trousseau sign? There is migratory. Migratory means once if it is here, next time it will be in the leg, next time it will be the other leg. Okay, so migratory. Thrombophlebitis means thrombus formation takes place. Phlebitis means there is inflammation of the vein. Okay, vein inflammation is called phlebitis. So superficial vein thrombosis and inflammation, which starts at one place, goes to another place, resolves. So that is known as migratory thrombophlebitis. Okay. So that is a characteristic feature of pancreatic adenocarcinoma. This is nothing but jaundice, obstructive jaundice, and next is Courvoisier sign. So what is Courvoisier sign? So remember, whenever there is painful gallbladder enlargement or painful gallbladder, the most common cause is gallstones and cholecystitis. But when there is painless dilatation of the gallbladder, that is seen in palpable non-tender gallbladder, that is known as Courvoisier sign, and it is very typical for pancreatic adenocarcinoma. Okay. So all these are KRAS is the driver mutation, P16, P53 are two tumor suppressor, the brakes of the car. Okay. So when they are lost, and along with that, smoking is a major risk factor, chronic pancreatitis, BRCA link is also there. Okay. So that causes all this pancreatic adenocarcinoma. Okay. So now, which is the marker? If you remember tumor markers chapter, C19.9 is for pancreatic adenocarcinoma. Now, what is this double bile duct sign on pancreatic CT? So when we do CT abdomen, so what will happen is, see here, if you can see here, okay. So this is the liver, okay. This is the gallbladder, okay, and this is the common bile duct. Okay, see here you are saying that this is a common bile duct. You will see that this is enlarged. Okay, that is common bile duct is enlarged. And this is the pancreas. Okay, say this is the pancreas. Okay, pancreas head. So this is the pancreatic duct, so that is also enlarged. So enlargement of both common bile duct and pancreatic duct is known as double duct sign. It is very a hallmark feature of this pancreatic adenocarcinoma. Okay, so cells also you will see like malignant cells, they are arranged in acinus. Okay, pancreatic acinus. So what is the treatment? One is it is poor prognosis, so very low survival rate. There is something known as Whipple procedure, where you cut the head of the pancreas and you cut part of intestine, you cut the gallbladder also. So then you anastomose everything. Okay, so this is called as Whipple procedure. If it is localized tumor, then only we go for Whipple's procedure. Anyways, it is not much, there is no much prognosis if the cancer spreads. New onset diabetes, because pancreas has endocrine role also, that's why new onset diabetes also should rise in a young person, should also make you think of pancreatic adenocarcinoma along with other Trousseau sign or something. Trousseau sign is this one, okay, migrated thrombophlebitis. If all that is given, then you should choose the answer as pancreatic adenocarcinoma. Also, CT pancreas is the preferred imaging for pancreatic adenocarcinoma. So let's go to the questions. What is the most common location? Very good. It is head of pancreas. Okay. What is the marker? Which marker is used for monitoring? CA19.9 for pancreas. In ovary, what we saw? CA125. CEA was for which one? It was for colon and also for pancreas. Okay. It was used for both, but here we are more concerned about CA19.9. Okay. Next, genetics, KRAS mutation, P53 mutation and P16 mutation. Which sign is migrated thrombophlebitis, which is a paraneoplastic syndrome? That is Trousseau. Okay. Next, spread of the tumor is early. There is early metastasis to the liver. So early liver metastasis. Treatment is Whipple's procedure if it is resectable. Okay. Which sign is seen? Palpable non-tender gallbladder. What is that? Courvoisier sign. Okay. Next, DASH may develop early diabetes. Okay. Next, what is the preferred imaging? CT abdomen. CT abdomen showing pancreas is the preferred imaging in pancreatic adenocarcinoma. So moving on to next topic, that is pituitary adenoma. From medicine also questions can be asked on this. We have a lot to discuss in pituitary adenoma because many questions can be asked from pharmac, from pediatrics, from medicine, from pathology. Okay, a number of questions can be asked on this topic. So understanding of concept is also very important for pituitary adenoma. So pituitary adenoma is when there is a growth in the pituitary which can cause increase in any of these following hormones. One is GH also it can cause. Okay, it can cause increased prolactin, it can cause increased ACTH, then it can cause increased gonadotropins. Okay, I'll write FSH-LH. Okay, so if it is increased GH which is causing it, it will cause acromegaly. Okay, GH producing pituitary adenoma. Increased prolactin is seen in prolactinoma, and remember, prolactinoma is the most common type of pituitary adenoma. If it is increased ACTH secreting, it is corticotroph secreting. Okay, and in this case, what will happen is increased ACTH causes Cushing's disease. Okay. So we'll see into some of these types. So one is prolactinoma, which is the most common. Now, what happens in prolactinoma is, you know that pituitary is under the control of hypothalamus. Okay, this hypothalamus controls pituitary. So hypothalamus secretes dopamine, okay, which inhibits prolactin. Remember, dopamine inhibits prolactin. But when this path is cut off, no? Like let's say there is some compression occurring here and dopamine can't reach here through the neuron endings, okay, nerve endings. So what will happen? There is no inhibition and prolactin will increase, and that is the most common cause of a prolactinoma, okay. So this is wrongly typed here. It is dopamine inhibits prolactin, okay. This is prolactin. Kindly make these changes in your PDF. Dopamine inhibits prolactin. Similarly, if there is a GH secreting adenoma, okay, from the pituitary, it is GH growth hormone secreting, then it will cause acromegaly in adults. In children, it causes gigantism, okay. Children will grow taller, they will grow bigger, but in adults, the bone fusion has already, epiphyseal fusion has already terminated. So there will be only acromegaly, okay, ends, mouth, all those, this, no, rough faces, all those will increase, okay. So that causes acromegaly in adults. So in acromegaly, what happens is because of increased GH, it will act on the liver, okay, and liver will secrete IGF-1, and this causes growth of the tissues. IGF-1 is the best screening tool to detect acromegaly, okay. It is not the confirmation test. For confirmation test, we use something known as GH suppression test, okay, growth hormone suppression test, which is the confirmatory test. Now it can be ACTH secreting tumor also, which acts on the adrenal gland and causes increased release of cortisol, okay, that leads to Cushing's disease, okay. It is not Cushing syndrome. Cushing syndrome is different, Cushing disease is different. When pituitary is involved, it is called Cushing disease, okay. So there will be increased ACTH from the pituitary. Now there are some other points also to be noted. What are the symptoms, okay? One is pituitary, no, pituitary is present below, okay, below the optic chiasma. This is the optic chiasma, pituitary is present below. These are the two eyes we are seeing, no, this is the right eye, this is the left eye. So pituitary is present somewhere below, okay. So when there is a large pituitary tumor, what happens is it compresses the optic stalk, okay, it compresses this optic chiasma. As a result of which the nerve fibers passing through this, see, this is the nasal fibers, okay, nasal fibers of both the eyes, the nasal fibers, okay, they are crossing each other, right? So at this point, pituitary is causing the problem. That's why what will happen is binasal, see here binasal, these fibers are affected, correct? But you remember that you should know that these nasal fibers, no, they actually see the temporal part of the vision, okay. Even though they are on the retina, it's on the nasal side, it is not on the temporal side, but they're seeing the temporal part of the vision, okay. It is like crossed like this, okay. That's why you will get bitemporal hemianopia. That is, on both sides of the temporal lobe there will be loss of visual vision field, okay. So that is the bitemporal hemianopia is a classic of pituitary tumor. On MRI, when you do, you can see adenoma. It causes snowman appearance. Okay, we call it a snowman appearance. But most of the time, what happens is there will be microadenomas which may not be visible on MRI. So that time, all these hormonal levels that will help us in guiding. Okay, the diagnosis. Now, which are the markers which are present? These are the transcription markers. Okay, one is PIT1 and TPIT. Remember, in almost all adenomas, PIT1 is used when 1 is expressed. Only in ACTH secreting tumors, TPIT is used, okay. So PIT stands for pituitary, okay. So T is in ACTH. Remember, ACTH producing tumors, okay. So whenever there is excess hormone, there will be clinical signs, okay. Related to each growth hormone, there will be clinical signs, which after that we'll do MRI, and in the sella turcica region, we'll see growth of pituitary. Then we'll classify which type of pituitary secreting adenoma it is, like whether it is GH secreting, ACTH secreting, etc. And then surgical treatment, then you'll give medical therapy, which is cabergoline. Now, what is cabergoline? Cabergoline is dopamine agonist, okay. So you know that what does dopamine do? Dopamine inhibits prolactin, okay. So it will inhibit prolactin, and this helps in prolactinoma. Okay, because prolactinoma is the most common type of pituitary adenoma. And what is the surgery? Transsphenoidal resection. We go through the nose, we go through the sphenoid sinus. Okay, you remember now, above the nose there is a sphenoid sinus. From there we go to the pituitary. Okay, so that is called as transsphenoidal resection. And then we follow up with the hormones. If hormone levels are increased, that means it has either recurred or there was some residual tumor which was not relieved with surgery. Now, medical treatment is cabergoline. Cabergoline is dopamine agonist. Now, if it is a GH secreting, growth hormone secreting hormone, we need something agonist for GH, right? So, what inhibits GH? Remember, I told you hypothalamus acts on pituitary. Now, hypothalamus secretes growth hormone releasing hormone, GHRH, which acts on pituitary. Then growth hormone is released. Now, growth hormone acts on liver. From here, IGF-1 is released, and IGF-1 is responsible for all the growth that happens in the body. Now, there is something which inhibits this GHRH, that is somatostatin. Okay. So, somatostatin analogs, they will be useful for growth hormone producing tumors. Okay. So, which is somatostatin analog? It is octreotide. Okay. Octreotide and pesireotide. Octreotide, pesireotide helps in growth hormone secreting adenomas. So this is the surgical approach. So if we go to the sphenoid sinus and we act on, we remove pituitary adenoma. Okay. So post-op we'll monitor for hormone levels, because on MRI we can't say if there is a microedema, something is left, we can't say. Now, few important things here also. Say, what is atypical adenoma? Okay, there are some atypical adenoma which are like little bit aggressive. Okay, pituitary adenoma. So in that we look for Ki67 level. What is Ki67? Ki67 is a marker for proliferation of cells. Okay, proliferation of tumor cells. So if this level is more than 3%, means it is more an aggressive pituitary adenoma. We term it as atypical pituitary adenoma. Okay. Next, what is silent corticotroph? I told you that corticotroph is ACTH secreting pituitary adenoma. Now, because of this, Cushing disease will happen. But in some cases, what will happen is Cushing disease doesn't happen, but ACTH is increased, and you can see pituitary adenoma also on the MRI. Now, why doesn't it happen? That is because whatever ACTH is produced from this, that is in non-functional. Okay, it is non-functional. Okay, but when you stain this tumor mass in biopsy, when you stain it, you will see that it stains positive for ACTH. Okay, so this is known as silent corticotroph producing pituitary adenoma. Okay, next, what is Stock effect? See, I told you prolactinoma. In prolactinoma, what happens? There is increased secretion of prolactin, and it is more than 250. Okay, 250 units, I think, is picogram. Okay, so more than 250, it is very high levels of prolactin. That is seen in prolactinoma. But what happens is, sometimes you can see this is the pituitary stalk. Now, if there is any mass compressing this, now what happens is, I said you, dopamine action doesn't take place, as a result of which prolactin will increase, and this mild increase in prolactin up to 250. Okay, 200 to 250. This is known as Stock effect. Okay, this is not a prolactinoma per se, but it is some other extrinsic compression which is causing like compression on the pituitary stalk. Okay, so these concepts are very important. That's why I thought I should explain this in depth, because any type of questions can be asked from this. So let's solve the MCQs. Which is the most common type of pituitary adenoma? It is prolactinoma. Okay. Next, mass effect is seen because of compression pituitary stalk. Okay, and this results in bitemporal hemianopia. What is the optic symptom that you get? Bitemporal hemianopia. MRI, what MRI imaging is used? MRI will see snowman appearance of pituitary adenoma, which is a marker. I said pattern. One is pit, another is T-pit. Okay, sorry, T-pit, pit 1 and T-pit, correct? Yes, pit 1 and T-pit. Treatment, what is the treatment for prolactinoma? Cabergoline. Okay, and what is the surgery that we use? Transsphenoidal resection. Okay. Atypical adenoma, so which elevation? Ki67 elevation, more than 3%. If prolactin is mildly increased, consider Stock effect. Okay, Stock effect is when it is mildly increased. If it is severely increased, very high, then you have to consider prolactinoma. If IGF-1 is increased, then it is growth hormone producing tumor. If ACTH is increased along with pituitary mass, then it is Cushing disease. Okay, Cushing disease. Next, growth hormone tumors need what analogs? Somatostatin analogs. Okay, so everything should be clear. I have taken more time to explain because it involves concepts. Next, we'll go to PCOS. Understanding PCOS pathology is crucial to understand all these MCQs. So first what happens is there is increased two things. Okay, one is increased LH. These are the two things, increased LH and increased insulin resistance. These two things determine whole pathology. Okay, so what happens is LH is more compared to FSH. It is more than 2:1. What happens when LH is more is, see, this FHS is responsible for this follicle maturation. You can see, this ovary. The follicle maturation responsibility is of LH. But what happens is of FSH. But since FSH is low, there is no ovulation because these mature and they get arrested at some point. Okay, they don't get completely mature and there is no ovulation that is taking place. As a result of which there are multiple subcapsular follicles which are present inside the ovary. Now, in addition to this, there is one more factor, that is insulin resistance. What this insulin resistance does is, it causes increased androgen production. There are two things here. One is increased LH also contributes to increased androgen because this LH acts on theca cells. Theca cells produce more of androgen, okay, testosterone. Now, along with this, there is also one more thing, that is insulin. Insulin resistance also contributes to androgen. So overall, there is increased androgen production in the body, which results in all clinical symptoms. Okay. So what are the clinical symptoms that you see? One is hirsutism because of increased androgens, acne because of increased androgens, irregular cycles is because this maturation of this one is not taking place because of decreased FSH. Okay, and because of insulin resistance only, you will have obesity, there will be hypertension, there will be dyslipidemia, impaired glucose tolerance. So all this will lead to metabolic syndrome. Okay, So basically there is metabolic syndrome, insulin resistance and anovulation. So this triad you see, that is called as PCOS. Now, I think I have explained all this. On USG, what you will see is you will see string of pearl appearance on USG because of multiple immature follicles which are still inside the ovary. Now, what is the treatment for this? Treatment is weight loss, OCP. Now, OCP is protective. That is because OCPs contain estrogen and progesterone, which actually decrease LH levels. Okay, that's why this OCPs are protective. And third thing is because of this chronic anovulation. Okay, ovaries are there, but ovulation is not happening. Okay, chronic anovulation, there will be increased estrogen. And do you remember when we were talking about endometrial carcinoma? Type 1 endometrial carcinoma was estrogen dependent because of hyperestrogenemia, and that's why endometrial hyperplasia risk is also more in case of PCOS. Okay. So what is this AMH? AMH is anti-Mullerian hormone, and this is secreted by the theca cells. Okay, that's why in PCOS where there is theca cell hyperplasia, it is common to expect high AMH levels. So this is one of the clue in MCQs that will be asked. On microscopy you will find theca cell hyperplasia. You can see here theca cell hyperplasia. Okay, and then during pregnancy there is risk of diabetes also. String of pearl appearance on USG also I have told. Okay. So LH FSH ratio is increased, it is more than 2:1, which LH is almost double that of FSH. Androgens, increased testosterone. Increased testosterone is released from these theca cells. Treatment, weight loss plus OCPs, okay, and then you give metformin. What levels are elevated in many cases? AMH, anti-Mullerian hormonal levels. What is prominent histologically? Theca cell hyperplasia, okay. And then DASH improves ovulation, metformin. Because metformin decreases insulin resistance, it also improves ovulation. And screen for what? Screen for metabolic syndrome. Okay. So metabolic syndrome, there are total 5 components. No? Centripetal obesity, hypertension, diabetes, hyperuricemia. Okay. So dyslipidemia. Okay. So these 5 components we'll have to screen for. Next we'll be seeing prostate cancer. We had seen earlier benign prostatic hyperplasia. Now we'll be seeing prostate cancer. Next topic, prostate cancer. So this is in contrast with benign prostatic hyperplasia because students get confused here, and your other options will be like prostatitis and UTI also. Okay, these will be your usual options. Okay, these 4 things. So basically prostate cancer you'll have to differentiate with BPH because many times you get confused between these 2 options only. See, BPH arises from transitional zone. Okay, BPH was arising from transitional zone, you had seen in last video, but prostate cancer arises from the peripheral zone. Important thing, one is zone of origin. Second is on microscopy, there in BPH you saw there was hyperplasia of glands. Okay, but here you will find acinus, that is glands are arranged in acinus, acinar adenocarcinoma. Okay, so on microscopy you will find crowded malignant glands. Okay, this is histological difference. Here genetics plays an important role. TMPRSS2 mutation is associated with the prostate carcinoma. Okay, TM, we have not come across this gene anywhere else before this. So for clinical, this one symptoms will be the same like benign prostatic hyperplasia only, and this is usually asymptomatic. Like prostate cancer, it is said that people don't die because of prostate cancer; they die along with prostate cancers because it is slowly growing cancer. Okay, so initially there will be no symptoms at all, but on digital rectal examination, there you will finding soft mass in BPH. Here it will be hard nodular mass. Okay, in prostate cancer, and very important in advanced prostatic cancer, there will be metastasis to the bone. Okay, remember. Bone metastasis, and these are not osteolytic lesions, these are osteoblastic lesions. Okay, this is very important NEET PG PYQ because everyone will get it wrong here. Everyone will think it is osteolytic lesion. So you'll do PSA, that is prostate specific antigen, but important thing is PSA can be increased in BPH also, it can be increased in prostatitis also. Okay, so this will be mild increase, but in prostate carcinoma there will be major increase in PSA. For staging of the tumor, you use MRI, okay, MRI of the prostate. Now, what do you find in histology after biopsy? You will find this prominent nuclei, all these glands arranged. So we use the scoring known as Gleason scoring, okay. Gleason scoring has, I have given Gleason, yes, yeah, it is given here, Gleason grading, okay. There are 2 types, one is primary pattern and secondary pattern, and we give score from 1 to 5, okay. So for prostate cancer, like for example, let's say it is based on actually the architecture of the prostate glands, okay. It is not based on anything else, it is based on architecture, it is not based on nuclei, atypia, it is not based on that, okay, not based on nucleus. It is based on the entire structure of the gland. I don't think you should go in depth also. So basically the commonest is 3+ plus 4 or 4 plus 3. That is primary pattern is 3 or secondary pattern is 4. Now, important to notice 3 plus 4 is not equal to 4 plus 3 because 3 plus 4 means primary pattern is little bit okay, secondary pattern is aggressive. But in 4 plus 3, primary pattern is aggressive and secondary pattern is less aggressive. Okay. So we'll start from total. We'll start from 6. Okay. So most common is grading score that we'll get is 7. Okay. For staging, we'll use body scan, that is PET scan also we'll use to see for bone metastasis. Treatment is simple. Treatment is surgical. We'll remove the prostate or based on the stage. Okay. And we give radiotherapy. There's not chemotherapy. And then among drugs, we give androgen blocking agents. Okay. This androgen deprivation therapy we call. Okay. One example for all that is leuprolide. I don't think you should go in detail with this mechanism and all. Okay. So I think I have explained everything important. So which type of adenocarcinoma is prostate? It is SNR type of adenocarcinoma. Zone, peripheral zone. In BPH we had a transitional zone. Mutation, TMPRSS2. Spread is osteoblastic. Okay, bone metastasis, which is osteoblastic spread. Grading is, which score is used? Gleason scoring is used. Next, imaging, we do MRI of the prostate for staging, which is a precursor lesion. We call it as PIN, which is known as prostatic intraepithelial neoplasia. Okay, so this is a precursor lesion of prostate cancer. Okay, which is seen on biopsy. So if PSA is moderately increased, then consider prostatitis also. Okay, and BPH also. If back pain is there along with increased ELP is related to bone, so that means there is bone metastasis. Okay, I think I have explained everything regarding this. So let's move on to next topic, that is pulmonary embolism, which is important from medicine aspect also. Okay, pulmonary embolism is relatively easy topic. Okay, so basically for pulmonary embolism to occur, there should be a source. Okay, and that source most of the cases is deep vein thrombosis. Okay, because of deep vein thrombosis, inside the venular part of the deep veins, you will get something known as red white laminated thrombus. Okay, this thrombus gets dislodged and then they go and block the pulmonary vessels. So if it is a postmortem clot, then it is known as lines of Zahn. Okay, so postmortem clot is known as lines of Zahn. Okay, so what will be the origin? DVT, some deep vein thrombosis which embolizes, clot travels to vena cava. From there it goes to the heart and then it goes to the pulmonary artery. Okay, that is from the right ventricle. So pulmonary, it causes block in the pulmonary artery, because of which what happens is if there is a block, now ventilation is coming. Okay, it is not a block in the airway. This is the airway. Okay, this is the pulmonary artery. So ventilation is there, but perfusion is not there because of this block. That causes VQ, that is ventilation circulation mismatch. Okay, then there is acute hypoxia because of this decreased circulation. Hypoxia occurs, cyanosis occurs. And on imaging, which is the imaging of choice, it is not ultrasound, it is not some MRI or anything. Okay, it is basically CT pulmonary angiography, CTPA. Okay, CTPA is the investigation of choice. So what is the initial management? Initial management is based on whether the pulmonary embolism is massive or not. If it is a very big massive pulmonary embolism, then we'll have to anticoagulate. Okay, so we give IV thrombolysis. Okay, we give thrombolytic agents. Okay, thrombolysis in case of massive pulmonary embolism when there is hemodynamic compromise, like there is obstructive shock or there is a cyanosis. In that case, we'll give this treatment. Okay, so dyspnea occurs, pleuritic pain occurs, tachycardia also occurs. Okay, D-dimer is a lab parameter which is sensitive, but it is not very specific to pulmonary embolism only, but it is sensitive. Which is the best investigation? It is CT pulmonary angiography. Okay. So this is massive pulmonary embolism causing shock. Treatment is IV thrombolysis. Okay. So what are some rare facts? If there is fat embolism, then we'll see petechia. Okay, petechia. And fat embolism occurs predominantly in MCQ. It is secondary to femur fracture. Okay, long bone, big bone fracture. We'll see fat embolism. There will be neurological signs also. Okay, chronic pulmonary embolism, if it is there, like small thrombus are forming over a long amount of time, then it causes pulmonary hypertension. Okay, pulmonary hypertension. So this is CTPA, CT pulmonary angiography, where you'll see there is some filling defect. Okay, and on ECG, this is very common pattern. S1, you see here, big S. Okay, what is S1? See, this is, just a minute. This is normal ECG, right? So this is P, this is S, this is Q, R, S, and this is T. So in S wave, okay, the first, always remember, it is this is the R wave. Okay, this is the R wave, and this is the S wave. So deep S wave. Okay, so that is called as S1. Q3 means there is so there will be Q wave which is not shown in this. Okay, so basically it will be like Q wave in lead 3. Okay, that is Q wave, and then there will be T wave inversion in lead 3. Okay, so this pattern is not specific for pulmonary embolism. This pattern tells you that there is acute right ventricular strain, okay, because of large pulmonary embolus which is occluding the pulmonary artery, because of that there is strain on the right ventricle. Okay, so that pattern is S1Q3 P3, S1Q3 T3. Okay, so thrombolysis in case of massive PV, otherwise we go with anticoagulation like heparin, or we'll go with warfarin switch over later on. Then IVC filter we use when we can't give thrombolysis. Let's say there is some patient is already on aspirin or something, we can't do thrombolysis. In that case, we'll be using IVC filter, which will be placed in inferior vena cava to prevent any clot from deep veins of legs to going into the inferior vena cava. Okay, so this is the full aspect of pulmonary embolism. Yeah, see here it is given S1Q3 T3, S wave in the lead 1, Q wave in lead 3, and T wave inversion. Okay, so this is T wave inversion over lead 3. Okay, so I think everything is covered. Okay, one more is Virchow's triad of coagulability. So S is for stasis, H is for hypercoagulability, okay, and E is for endothelial injury. Okay, so this is about blood coagulation. Okay, so let's solve MCQs. Which is the best imaging test? It is CTPA, CT pulmonary angiography. ECG, what pattern is seen occasionally? S1, Q3, T3, and it doesn't indicate pulmonary embolism, it indicates acute right ventricular strain. Okay. Next, which lab parameter is increased? D dimer, which is sensitive, but it is not very specific for pulmonary embolism. Okay. What shows petechia neurological signs? It is nothing but fat embolism. Okay, fat embolism occurs in long bone, big bone fracture like femur fracture. If sudden dyspnea and tachycardia, suspect pulmonary embolism, because you don't get specific signs in pulmonary embolism. It is sudden onset, one, there is dyspnea and there is tachycardia. Okay, so if that is there in the question, then you can go ahead with pulmonary embolism. Okay, you should keep that as an option. Thrombolysis indication is if there is massive pulmonary embolism. Okay, next, if anticoagulation is contraindicated, you use IVC filter when there is deep vein thrombosis. Okay. So that's it about pulmonary embolism. Next we'll go to renal cell carcinoma. Next topic is renal cell carcinoma. So basically in renal cell carcinoma only very high yield points are asked. One is origin of renal cell carcinoma is always cells of proximal tubular epithelium. So your 4 options will be different. Out of it you have to select PCT. Okay. So it is clearly mentioned in this image. You are seeing here PCT. So this proximal convoluted tubule, okay, this part, okay. So from there cells will arise, and there are basically 3 type of renal cell carcinoma that you have to remember. One is the most common, that is clear cell carcinoma, which has associated VHL. Now remember, where did you find VHL gene? Yes, it was in one Hippel-Lindau disease, okay, where you had studied there will be retinoblastoma, there will be medulloblastomas, there will be associated clear cell carcinoma also. We had seen this before also, okay. Similarly, one more type is papillary cell renal cell carcinoma, which is associated with MET mutation, MET. MET is for papillary carcinoma of renal cell carcinoma. Okay. Next is chromophobe type, which has got best prognosis. And there's one more variety, which is pediatrics. So what happens is, because of this TFE3 gene rearrangement, there will be XP11 translocation, okay, which gives rise to new subtype of renal cell carcinoma, which is common in pediatric age group. Now this needs to be differentiated from Wilms tumor, because Wilms tumor is also more common in pediatric age group, okay, especially first 2 years of life. Okay, so basically clear cell carcinoma accounts for around 70% of the total cases of renal cell carcinoma, and here mutation is with the 3P loss. Okay, so VHL, which codes for hypoxia inducible factor, this gets inactivated. Okay, so there is transformation of the cell. There will be lipid accumulation within these cells, okay, within this proximal tubular cells, and it will give appearance of clear cell under microscope. Okay, that is the reason we call it as clear cell carcinoma. Now then it has more of local spread, so it can invade into the renal vessels, especially causes renal vein thrombosis. Okay, and then metastasis is mainly towards lungs and bones. So on gross imaging, what do you find? Before that, yeah, on gross imaging, what do you find? You find yellow tumor, which has more lipid content, and on histopathology you'll find clear cells, that is you won't find any staining material within, okay, because of this lipid deposition, and it is also prone to cause renal vein thrombosis, and it can also enter into the IVC, causing IVC thrombosis. What are the risk factors? Risk factors are smoking, obesity, all these are common things. I think no need to explain much in depth. Symptoms will be simple. So there will be hematuria, flank pain, and palpable flank mass. So your main job in MCQ exam is to differentiate between other causes which cause painful hematuria. Okay, so this causes painful hematuria. Okay, there will be flank pain also, there can be hematuria also. So you have to differentiate from other causes where there can be painful hematuria. So what are the paraneoplastic effects? See, kidney produces things such as erythropoietin. It also produces vitamin D activating enzyme, that is 1-alpha hydroxylase. It also produces renin. So whenever kidney cells are mutated, no, it causes increased production of these things. So that can be polycythemia, okay, increased HB. There can be metastatic calcification, and there will be hypercalcemia, and there will be hypertension. So these are the paraneoplastic effects of renal cell carcinoma. Okay, so diagnosis is mainly by CT abdomen, where you do staging also, and then treatment is by nephrectomy. You just cut that particular piece of kidney whichever is affected, and then we'll see in surgery how staging differs. Okay, so main modulator here is VEGF. Okay, so VEGF inhibitors, targeted VEGF inhibitors, have more role in renal cell carcinoma. One important VEGF inhibitor, okay, that is monoclonal antibodies against VEGF, is bevacizumab. Although it is not used commonly nowadays, but you should still know bevacizumab still was used earlier for renal cell carcinoma. Nowadays, targeted VEGF in the form of TKI inhibitors are used, and most common is sumatinib. Okay, sunitinib. Okay, SUNI, sunitinib, and there is sorafenib. Okay. So just remember TNIPs, okay, and one VEGF inhibitor, monoclonal antibody, that is bevacizumab, which is commonly asked. Okay, so some important thing that you should note is that there always hematuria doesn't occur in renal cell carcinoma. Other symptoms also can be asked, and paraneoplastic symptoms also can be asked. So don't always expect hematuria. Second is always renal vein invasion won't be there in the question, so don't just rely on that. And third is thinking that angiomyolipoma is malignant. So it's not malignant. Okay, so angio means blood vessels, myo means muscles, that is smooth muscles, and lipoma means fat. So it consists of all these three. It is benign. Okay, so it is not like liposarcoma. It is angiomyolipoma and not angiomyoliposarcoma. So that's how you remember. It is associated most commonly with tuberous sclerosis. Okay, so tuberous sclerosis association is there. And third thing is it can bleed. It has more tendency to bleed because it contains blood vessels, right? So it can cause retroperitoneal hemorrhage. So any question where there is a mass in the kidney and it has caused retroperitoneal hemorrhage, then your answer should go towards angiomyolipoma. Okay. So these are the mnemonics which you can use to remember things like clear cell, like C for cytoplasm, C for common. Okay. Similarly VHL. Okay. And next the triad of renal cell carcinoma. Okay. Hematuria, heavy mass, and HERD, that is painful. Okay. So which is the most common type of RCC? That is we have talked so far, clear cell carcinoma. Okay. Next origin will be proximal convoluted tubular epithelium. Okay, mutation chromosome 3. Always remember VHL is a very important mutation. It is asked in many places. Treatment is nephrectomy. Okay, nephrectomy if it is localized. If it is metastasized, then you use TNIPs. Okay, TNIP group of drugs, that is tyrosine kinase inhibitors. So tyrosine kinase inhibitors. Okay, and then one more is bevacizumab, which is also asked in the question. Okay, next, which RCC involves MET mutation? We have seen papillary carcinoma. Okay, next, which RCC has best prognosis? Chromophobe. Okay, chromophobe. Next, which translocation? XP11 translocation, TFE3 mutation leading to XP11 translocation. Okay, VHL deletion is related to renal cell carcinoma. Which type? Clear cell. Okay, next, targeted dash inhibitors useful. VEGF inhibitors are useful in advanced disease. Okay, in advanced disease we use it. Others we use TNIF, that is sorafenib and sunitinib. Okay, next, which is best for evaluation? CT abdomen is the best for evaluation. Okay, so these are the things you need to know about renal cell carcinoma. Next we'll go to retinoblastoma. Okay, so going to retinoblastoma, few very important questions are asked from this topic. First, you should know why retinoblastoma occurs. RB1 gene, I think there is no confusion regarding this. There are two hits. Two hits means both RB1s present on two alleles, both should be hit for retinoblastoma to get activated. Okay, so first hit usually is based on genetic. Okay, so there is some mutation already, and second hit is usually environmental. Okay, so once there is biallelic loss, and then what happens is retinal proliferation occurs. You can see here retinal growth occurs. Once retinal growth occurs inside the eye, this retinal growth is very rampant. Okay, it grows very fast. That's why these tumor cells and all, they will die because of necrosis and all. So because of which there will be calcification, dystrophic calcification, if you remember. Okay, so because of this, a mass appears inside the eye which covers the retina. Normally what happens is when you see on direct ophthalmoscope, okay, DO, you will see a red reflex, okay, a red reflex. Normally red reflex is seen, okay, this is red reflex normally. But what will happen is because of this tumor mass, okay, it appears as white, okay, so it will get white reflex. So white reflex, anytime think of a retinoblastoma, okay, so we call it as leukocoria. So white reflex on direct ophthalmoscopy is seen in retinoblastoma. Now, how does this present? Presents with mass, some leukocoria, okay, and there will be calcified mass, there will be optic nerve involvement. There can also be strabismus. That is because one side of the eye patient can't see at all. So the other eye tries to balance it out, okay. So it's like blindness only, okay. So that's why there will be squinting. And next is there can be direct optic nerve extension of the tumor also, okay. And subarachnoid space also extension can occur, okay. So on pathology, what you can say important is this flexner intestine rosettes. If you remember, there was something known as Homer red rosette, okay. Homer red rosettes, which I had already seen in neuroblastoma, okay, mainly in neuroblastoma, medulloblastoma. So this Homer red rosettes actually had a lumen which was filled with some material, okay, but it was not a true lumen, okay. But this flexner intestine rosette, these are also the cells of retinoblastoma which have a true lumen, okay. So this is a true lumen which is seen in flexner intestinal, but in Homer rosette you will find a false lumen. That is because of the accumulation of necrotic material. Now on pathology is calcified intraocular mass, which will be there, okay. Calcified, why I told that. So going to the treatment is basically removal, depends on the stages, okay, but standard treatment is chemo we give basically VEC regimen, okay, VEC regimen, okay. V stands for vincristine, okay, E stands for etoposide, and C stands for carboplatin, okay. And along with this we do enucleation, okay. It depends on the staging, but to be on simple terms, it is enucleation, removal of the eye. Okay, now follow-up is required for secondary malignancy, because I told you already that RB1, retinoblastoma 1 gene, is a tumor suppressor gene. So when tumor suppression is affected, I told you it is between G1 to S phase of the cell cycle. We already discussed it 1-2 hours prior. Okay, so that means that once this is affected, many other cells also can undergo transformation, right? So the most common out of them is osteosarcoma. So remember, osteosarcoma is the other malignancy which can be related to RB1 mutation. Okay, so there is something called as chemo reduction. What is chemo reduction? When the tumor is big, no, like it is spreading or there is metastasis, what we try to do is we try to reduce the size of the tumor so that we can operate it, okay, selectively by giving chemotherapy. Okay, that is known as chemo reduction. Okay, and prognosis is good if it is detected early. That's why retinoblastoma is an emergency. Okay, so I think we are good enough to go ahead with the fill in the blanks. Okay, so so one more important thing which I had wanted to tell you is it can be bilateral. Okay, in case of hereditary retinoblastoma, I told no, like if there is already genetic association, there is only one hit that is required. That is in genetic cases. So in those cases, there will be bilateral affecting, and it can lead to bilateral retinoblastoma. If this bilateral retinoblastoma is associated with pineal tumor also, okay, in the brain, pineal tumor, then it is known as trilateral retinoblastoma. Okay, so bilateral is seen in hereditary cases. Hereditary, there is some genetic mutation in the RB1 gene. Histology, we see Flexner Wintersteiner rosettes. Okay, Flexner Winterstein rosettes. Okay, Flexner Wintersteiner rosettes. Okay, complication risk of osteosarcoma later on. Okay, osteosarcoma and other secondary malignancies also. Treatment is chemo, that is VEC regimen plus enucleation, plus or minus enucleation. Okay. Next, trilateral retinoblastoma includes pineal tumor, okay, pineal gland tumor. Dash loss also involved P16, okay. P16 is one more gene which loss is also seen in retinoblastoma. If calcified intraocular mass, think of retinoblastoma. Next, dash is used for optic nerve involvement. We use MRI. MRI is used to see for optic nerve involvement, okay. So this is the most important things from retinoblastoma. Next we'll see thyroid cancer in depth. Okay, thyroid carcinoma, many important questions are being asked. Okay, so first you should know what is a mutation that causes thyroid carcinoma. One is BRAF mutation and one more is RET. Now remember, where did you hear BRAF mutation? Yes, very good. BRAF V600D you had also seen in melanoma. Okay, when you were going through melanoma, there also we had discussed. So RET mutation is also there. We'll go in depth with each of this. Okay, so initially mutation occurs, then there will be differentiation into any one of these 4 subtypes. Okay, one is papillary, follicular, medullary and anaplastic. So the best initial test, okay, remember in thyroid carcinoma, the only which we are concerned about is FNAC. Okay, so best initial test is FNAC. Then what we do is we go for option that is surgery thyroidectomy. We do staging also. Then there is adjuvant therapy using radioiodine therapy, where we use iodine 131, or we use palliative approach for carcinoma such as anaplastic carcinoma. Then we do surveillance with the tumor markers, which we'll be discussing. So out of this, the most important carcinoma is papillary thyroid carcinoma, which is the most common also, associated with BRAF mutation, and very important is orphan ani nuclei and psammoma bodies. So whenever I say orphan ani nuclei, remember papillary carcinoma of thyroid. Psammoma bodies are seen in various types, like we also saw it in papillary ovarian carcinoma, that is serous adenocarcinoma of ovary also. We are seeing in thyroid carcinoma also. Very important thing is spread is via lymphatics. So lymphatic spread is the most common. We also know that for all carcinoma, lymphatic spread is the most common. But see here, in follicular carcinoma, this is an exception, okay? For all, follicular carcinoma is one carcinoma which, being a carcinoma, has hematogenous spread. Why does this occur? Because follicular carcinoma has massive invasion of blood vessels. Invasion of blood vessels. Because of the blood vessel invasion, it spreads by hematogenous route, okay, not by lymphatic route. That is one major difference between papillary carcinoma and follicular carcinoma, okay, and it spreads to bone and lungs, okay. So everything is given in the image form. Now, third type of carcinoma is medullary carcinoma. So medullary carcinoma is related to RET mutation, okay, and it is associated with MEN2. So what else is there in MEN2? So MEN2A has three organs. One is parathyroid, okay, parathyroid. One is thyroid, that is medullary carcinoma, okay, and third is pheochromocytoma, okay. So MEN2A and MEN2B also it's a part of, okay, it's a part of MEN2B also. So the marker is basically this medullary carcinoma of thyroid originates from the C cells of thyroid, okay. So there's something known as calcitonin secreting C cells within the thyroid. From there it originates, okay. So the marker itself is calcitonin, and because of this calcitonin there is amyloid appearance, okay. So this calcitonin gives amyloid stroma, okay. This is amyloid inside the thyroid stroma, okay. So amyloid stroma appearance for thyroid carcinoma. So all these are keywords that you need to search in your MCQs. Next, fourth type is anaplastic carcinoma, which is very aggressive and seen in elderly, okay. So very aggressive behavior, and here we have associated P53 mutations, okay. So this doesn't have any cure, it is palliative, okay. So how to remember four types of thyroid carcinoma? P is for papillary, papillary is for psammoma, okay, and it is for popular, which means most common, okay. The second is follicular. Follicular, remember one thing, that is it spreads far, that is means hematogenous, okay. M is for medullary thyroid carcinoma associated with MEN2, and there is marker also which is calcitonin. And anaplastic is A, which is aggressive and seen in aged people. So there is no treatment, there is only palliative treatment. So BRAF V600E mutation is commonly seen in papillary carcinoma of thyroid, okay, papillary carcinoma of thyroid. Which are calcitonin producing C cells, they are seen in medullary carcinoma of thyroid, okay. Next, RET mutation is associated with the MEN2 syndrome, which is associated with the medullary thyroid carcinoma, okay, which is very aggressive and seen in elderly. Remember, A for age, A for aggressive, it is anaplastic. Which is the best initial test? It is FNAC. And which variant resists radioiodine? See, radioiodine is used as a treatment, I told, iodine 131. So basically, there is one variant known as Hurtl cell variant, okay. Hurtl cell variant which resists radioiodine, whereas medullary thyroid carcinoma and anaplastic also have some radioiodine resistant properties. But in MCQ, if it is asked, remember Hurtl cell carcinoma. If vascular invasion, I told you, always remember follicular carcinoma of thyroid, okay. So I think I have discussed almost everything. So this single image has so many MCQs. I think around 15 MCQs can be asked based on just images given in this single slide. Next, we'll go towards vasculitis. Again, a very important topic to be covered. A very high-yield topic, especially when it comes to pathology, pediatrics, and medicine. This is vasculitis, okay. So basically, classification is according to Chaper-Hill classification, okay. This is the system of classification. But the problem is there are so many extra things, especially in small vessel vasculitis. You don't have to remember everything, but you should be careful about at least these basic things which I am discussing. Large vessel vasculitis, there are two types. Okay, one is GCA, that is a giant cell arteritis, or also known as temporal arteritis, that affects mainly the head and neck part. Okay, and the second is the one which affects the aorta and its branches, that is Takayasu. So there are only two types. Okay, in Takayasu, what happens, because of there will be narrowing of aorta and its branches, especially subclavian. Okay, subclavian arteries are affected, because of which there will be no pulse in the arm. Okay, so this pulseless arm is example of pulse deficit, is example of Takayasu. Okay, in medium vessel, there shouldn't be any confusion regarding large vessel. In medium vessel, there are again three types, out of which two types you have to remember at any cost. One is vasculitis, which affects mainly kidneys and skin, that is known as PAN, that is polyarteritis nodosa. Second is seen in pediatric population, which affects the heart, and it causes wide variety of other symptoms along with the mnemonic CREAM. Okay, CREAM stands for conjunctivitis, rash. E is for edema. Okay, so let me write this because this is important. Okay, CREAM. C is for conjunctivitis, that is bilateral non-purulent. Okay, non-purulent conjunctivitis. R is for rash. Okay, E is for edema or erythema of the limbs. Edema of the limbs will be there. A is for adenopathy, that is lymphadenopathy, and it should be unilateral. Okay, unilateral cervical lymphadenopathy. And M is for mucositis. Okay, mucositis means inflammation of the oral mucosa. Okay, so these are the 5 features of Kawasaki, and along with that it causes heart coronary aneurysm. Okay, that is the most dreaded complication of dreaded means dangerous complication of Kawasaki. Okay, and then we have small vessel vasculitis, and in small vessel vasculitis we have 3 important vasculitis. Okay, one is GPA. Okay, I'll write short forms first. GPA. Second is MPA, and third is EGPA. Okay, so GPA is granulomatosis with polyangiitis. PA is all polyangiitis. Okay, this is microscopic polyangiitis. And EGPA is eosinophilic granulomatosis with polyangiitis. Okay, so in this, important thing is granulomatosis with polyangiitis was earlier known as Wegener's. Okay, and eosinophilic granulitis was known as Churg-Strauss syndrome. Churg-Strauss you would have heard of. Okay, which is associated with asthma also. So basically it affects lung capillaries, kidney glomerulus, and sinus. Okay, we'll see how to differentiate this. One important thing you should remember is pathology wise, this vasculitis shows fibrinoid type of necrosis. Okay, so remember which type of necrosis occurs in vasculitis. It is fibrinoid. Okay, so now how do we differentiate small vessel vasculitis? There is something called as C ANCA and P ANCA. Now what is C ANCA, what is P ANCA? Basically they are the stains. Okay, so when you stain the nucleus, okay, so what pattern is seen? Okay, or the cell. Okay, sorry, the cell. Okay, so if it is C ANCA, means cytoplasmic stain is uptaken. Okay, so in cytoplasm there is something called as proteinase 3. Okay, this molecule takes up the stain and hence it appears as cytoplasmic stain. So this is known as cytoplasmic ANCA. Basically these are antibodies. Okay, they are nothing but else but antibodies directed against those specific targets. Here it is proteinase 3. And in P ANCA, these antibodies are targeted against perinuclear area. Okay, especially myeloperoxidase. So it is known as P ANCA. Okay, so now based on C ANCA and P ANCA, we have two different categories. Okay, MPA and EGPA, that is microscopic polyangiitis and Churg-Strauss syndrome, they have C ANCA positivity. And granulomatosis with polyangiitis, that is, sorry, this has P ANCA positivity. And Wegener's granulomatosis, that has C ANCA. Okay, that is what is given here. Okay, so C ANCA is seen in granulomatosis with polyangiitis, that is Wegener's, and P ANCA is seen in MPA and EGPA. Okay, so this question always comes in exam, so you are not supposed to forget it. Just see this image and you will never forget it. Okay, now EGPA is associated, that is Churg-Strauss syndrome. It has eosinophilia along with asthma. Okay, and polyarteritis nodosa spares lungs. This is one important point, because if you see here, this polyarteritis nodosa you often confuse with the microscopic polyangiitis. Okay, polyarteritis nodosa is what? Polyarteritis nodosa is something which affects kidney. Remember, it affects kidney. It affects the skin also, but it is a medium vessel vasculitis. Whereas microscopic polyangiitis is a small vessel vasculitis. Okay, and it is what positive? It is P ANCA positive. Okay, and it spares lungs. Okay, PAN spares lungs, and MPA MPA affects lung. Okay, so you can see here, no, small vessel vasculitis, it affects lungs, but this PAN doesn't affect lung. PAN spares the lung. Okay, always remember that. Okay, next. Takayasu pulse deficit I have already told. So whenever there is symptoms of vasculitis, there can be fever, weight loss, ischemia, there can be gangrene, okay, there can be Raynaud's phenomenon, okay, all this happens with respect to vasculitis, okay, headache can be there, seizures can be there, many symptoms can be there. Now first you have to categorize whether it is large vessel, medium vessel or small vessel, then we send for ANCA. We'll see whether it is C ANCA or P ANCA type of small vessel vasculitis. Okay, then we'll do the biopsy of the tissue sample and then we start treatment. Okay, so treatment is basically high dose steroids and then we give immunosuppression using other agents. Okay, so some clinical clues in your MCQs will be for giant cell arteritis, it will be jaw claudication and vision loss. And remember, in temporal arteritis, vision loss is very important because if you don't treat on time, then this vision loss can be permanent also. Okay, so it is that important. Giant cell arteritis is mainly seen in elderly patients. Okay, it is seen in elderly patients, usually more than 50 years. Okay, more than 50 years. Next, in pediatric age group, you see Kawasaki, and for Kawasaki, the treatment is IVIG. Okay, it is not steroids, it is IVIG. If there is renal and lung, both are involved, then it can be either Wegener's granulomatosis or it can be microscopic polyangiitis. Now, how do you differentiate between these two? Microscopic polyangiitis is P ANCA positive and Wegener's is C ANCA positive. Okay. Okay, so high dose steroid is the first line of treatment. In severe cases where especially renal involvement is there, we'll give cyclophosphamide. Okay, so all these mnemonics you can see on your own. Let's solve questions. In which coronary aneurysm risk is there? It is seen in Kawasaki disease. Okay, so Kawasaki is a form of vasculitis which affects coronary vasculature. What shows eosinophilia and asthma? It is nothing but Church-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. Okay, PAN, very important. PAN spares which organ? It spares lungs, but MPA doesn't spare lungs. Okay, it involves lungs also. C ANCA positivity is seen in, again, GPA, that is Wegener's granulomatosis. We see C ANCA positivity. If asthma and eosinophilia are there, suspect what? Suspect Church-Strauss syndrome or EGPA. If pulseless limb, it is Takayasu. Okay, I think rest of the things I have covered. High dose steroids is the treatment. Cyclophosphamide is used for severe cases. Kawasaki treatment is IVIG. These are the basic things you should know. Above this, we'll discuss in medicine. Okay, we'll have to go to systematic wise for medicine. That we'll be discussing during medicine. Okay, so next is pneumoconiosis, another very important topic asked in pathology. So the word pneumoconiosis itself has a meaning. Pneumo means lung, conio means dust. Okay, so it is nothing but dust induced lung disease. Okay, dust induced lung disease, and we have mainly three types in this. One is exposure to dust mainly during sand blasting and mining. Okay, sand blasting and mining especially occurs in the mines and all. Okay, so this is what is known where silica deposition happens. Okay, this is silicosis, and you can see here silicosis, there is upper lobe fibrosis. Very, very, very important point, differentiation during exams. Second is in shipyard and in construction work, there can be asbestosis. Okay, asbestosis occurs with lower lobe fibrosis and there will be pleural plaques. Okay, so this is in case of asbestosis. And third is in case of coal workers where dust will be deposited throughout. Okay, black spot, these are known as anthracosis. Okay, so three types of dust induced lung disease or pneumoconiosis is what we are worried about. So anytime a person inhales some dust, it may be silica, maybe asbestos, or maybe coal particles. Okay, so what happens is inside the lung, it causes activation of macrophages. Okay, so there is impaired macrophages activation and these particles get trapped within the macrophages. Okay, which finally leads to fibrosis and scarring of lung tissue, leading to restrictive lung disease. So this causes restrictive lung disease, not obstructive, restrictive. Okay, and then other symptoms occur and then complications occur. Okay, so what are the main imaging points to differentiate? See, this is the visual mnemonic for this. Silica, yes, yes is for superior, so upper lobes of the lungs are involved. Okay, similarly asbestosis, A for architecture, so shipbuilding or some work on the base or construction work. Okay, so all those causes base means lower part of the lungs. Okay, so lower lobes. Important thing is on microscopy, that is, see here, In asbestosis, you will get something known as, when you see under microscope, this silicosis, you find, you can see, these particles, these are silica particles, okay? But these silica particles are radiating light, okay? When you pass polarized light through them, it splits the ray of light into two different beams, okay? That's why we call it as a birefringent, means two type of rays are split apart, okay? So this is seen in silicosis, okay? Can you name one more thing where birefringence is seen? Yes, very good. In amyloidosis also, okay? And on X-ray, you will find eggshell type of nodules. This calcified nodules, they give appearance of eggshell, okay? Cracked eggshells, okay? So this is for silicosis. For asbestosis, these asbestos bodies, around them, hemosiderin will be deposited. So iron deposition takes place. Hence, it is known as ferruginous bodies, which are dumbbell-shaped fibers. So these asbestosis fibers are covered with iron and proteinaceous material, which are known as ferruginous bodies. Okay. So most important thing is imaging only. Okay. One is in silica, you get upper lobe fibrosis with upper lobe nodules with eggshell calcification. Okay. And in asbestosis, you get lower lobe asbestosis along with pleural plaques. Okay, now why is pneumoconiosis so feared is because of its risk for malignancy, and the most common malignancy is not mesothelioma, it's bronchogenic cancer. Okay, remember, bronchogenic cancer is the most common. Mesothelioma also occurs in asbestosis. In silica, there is increased susceptibility for TB also. This is one rare fact where rheumatoid arthritis, when it is associated with these pulmonary nodules in pneumoconiosis, it is known as Kaplan syndrome. Okay, this has been asked in MCQ, especially INICET, a few times. Okay, so mesothelioma is related to the pleura, it is not adenocarcinoma. Okay, next, asbestosis occurs in the upper lobe, correct? Sorry, asbestosis occurs in the lower lobe, silicosis occurs in the upper lobe. Coal workers pneumoconiosis may not be always severe. Okay, it can be in the initial stages also in the exam. Okay, so these are ferruginous bodies, ferritin in the asbestos. Okay, so let's go to the questions and we'll see. So mining, sand blasting, silicosis, okay, it causes upper lobe fibrosis. Construction, shipyards and asbestosis, it is lower lobe fibrosis. Okay, so birefringent eggshell nodules are seen in silicosis. Sorry, I went to the next question. Okay, so this is silicosis. Coal dust, coal workers causes anthracosis. Okay, asbestosis pathology is which bodies? Ferruginous bodies. Risk of asbestosis causes increased risk of which cancer? Mesothelioma. Okay, asbestosis specific is mesothelioma. Okay, which syndrome is rheumatoid arthritis with pneumoconiosis? Kaplan syndrome. Pleural plaques are seen in asbestos, not silica. Okay, ferruginous bodies are again seen in asbestos only. Next, which carcinoma risk is higher? Bronchogenic carcinoma. Okay, so higher risk is of bronchogenic carcinoma, specific is mesothelioma. Okay, so I guess that is clear. We'll go to next topic, a broad overview of autoimmune disease, very important from microbiology and pathology point of view. Again, introductory topic. Okay, so basically what happens is in all autoimmune disease, there is almost always a genetic risk. Okay, a genetic trigger will be there. Usually what you need to remember for exam is this HLA-B27, HLA-DR3 and HLA-DR4. These are the most common things which will be asked for you. Okay, so based on this genetic risk, there will be a trigger. This trigger can be some infection, or there can be some molecular mimicry. Something will be there, some trigger will be there, which leads to something known as tolerance breakdown or tolerance breach. Now what is this tolerance? See, our body has, you see this image, our body has ability, our T cells have the ability to identify which are foreign cells and which are our own body cells. This is known as tolerance. And once this tolerance is broken down, we call it as tolerance breakdown or tolerance breach. So there is failure to recognize the cells, which are our own cells, it fails to recognize. So this can be either central loss of tolerance or peripheral loss. Okay, central means the factory from where T cells are produced, that itself is problematic. So it can be either thymus or it can be bone marrow. Okay, so there is any defect in both this, it causes central tolerance breakdown. Okay, peripheral is in the form of T cells. Okay, T cells, or it through defective like apoptotic pathways. Okay, so such features are related to peripheral loss of tolerance. So once this tolerance is broken down, then autoantibodies are produced against own body cells, and one of the main mediators of this is Th1 cells and Th2 17 cells. These are T helper cells, Th1 and Th17. These are the only two cells you need to remember in case of autoimmune diseases. Then it causes tissue injury, and these are relapsing remitting course. All this you know. So examples are, I think I don't have to go in depth also, just go through this. Okay, so these causes, what it causes, production of autoantibodies. Okay, so like for example, anti-nuclear antibodies, which are directed against the nuclear antigens. Okay, so nucleus is the target. Similarly, in rheumatoid factor, there is Fc region target. Okay, similarly in anti-dsDNA, there is DNA helix is the target. Okay, so these are few antibodies example. Okay, and main mediators are Th1 and Th17. Okay, there is something known as epitope spreading. So what happens is, if a antibody or a cell, T cell, identifies a type of epitope. What are epitopes? Epitopes are small receptors of protein present on the cells. Okay, so once it recognizes, then it will start to damage this. Okay, antibodies are produced against that epitope. But what will happen is, in autoimmune diseases, initially against a particular epitope, let's say this is epitope number A, against this antibody is produced. But what happens as the disease progresses, antibodies are produced against other epitopes also. So this is known as epitope spreading, and this is classical of SLE, mainly in SLE. That's why initially you might get only anti-dsDNA, but later on you might also get anti-UNRNP. Okay, it can also cause anti-Smith antibodies. So the antibody profile changes in SLE. Okay, this is because of epitope spreading. One more concept is the concept of T regulation, T regulator cells. Okay, these are the ones responsible for controlling inflammation, for controlling keeping T cells under check. So when there is T cell dysfunction, that time also autoimmunity occurs. Okay, so we have some visual mnemonics to remember HLA. So B27, say B is for back. Okay, so B is for back. So this is seen in ankylosing spondylitis. Similarly, in SLE, we have anti-dsDNA activity. Okay, and in rheumatoid arthritis, symmetric small joint involvement is same. Okay, so we'll see through the questions. Which type of cells? Th1 and Th17. These both are involved in driving inflammation in autoimmunity. Which dysfunction is central to pathogenesis? T regulatory cell dysfunction. Okay. Next, HLA B27, ankylosing spondylitis. Anti-dsDNA is seen in SLE. What is the most specific antibody for SLE? If you ask me, it is anti-Smith. Okay. Anti-Smith antibody is the most specific for SLE. Low C3-C4 means complements are getting consumed during this inflammatory process. It occurs in SLE. Okay, so that's why in question sometimes there could be a case of nephritis. Okay, nephritis or nephritic syndrome, where C3-C4. Classic question will be C3 is decreased, C4 is decreased. What is your diagnosis? It becomes SLE. Both of these will be decreased. If C3 is decreased but C4 is increased or normal, then it could be a case of PSG, post streptococcal glomerulonephritis, because here only C3 gets decreased. Okay, hypocomplementemia, and later on after 3 months this levels increases. Okay, and also there are other features also which are seen, like for example in microscopy also there is difference in the immunofluorescence. There is difference in SLE and in SLE find full house immunofluorescence, means all type of antibodies are deposited, so you will get a big fluorescence of all type of antibody positivity. Okay, whereas in nephritic we'll get hump, subendothelial hump deposition. Okay, and in PSGN this is known as starry sky appearance. Okay, starry sky appearance of immunofluorescence. Okay, so these are some clinical questions which you should be able to apply during your exams. Okay, next we'll go to easy topic relatively. Okay, hypersensitivity reactions, a very important topic. Always students get wrong in this because you don't memorize it properly. Okay, as simple as that. So there are basically 4 types of hypersensitivity reactions. Things are simple. There will be some foreign molecules, there will be immune response mounted against it. Okay, and then there will be some mediator release, immediate mediator release like cytokines and histamine, causes some tissue injury, inflammation, cell damage, and there will be some targeted therapy for this, especially antihistamine, steroids, and some immunosuppressants in severe cases. Okay, so hypersensitivity is exaggerated response of the immune system basically. Okay, so now what happens in type 1? Okay, type 1 is, main thing is it lasts for minutes only. Okay, it is few minutes, within like 1 hour the inflammation gets subsided. So here what happens is there will be mast cell. Okay, whenever these cells come in contact with some allergen, see mast cell comes in contact with allergen, there will be IgE on the mast cell. Okay, so IgE there on the mast cell, allergen will sit on this. Okay, and then mast cell degranulation happens, during which main molecule is histamine. Okay, histamine is mediated. Also there is leukotrienes which are also mediating this reaction. Okay, so because of this, certain things happen like anaphylaxis. Okay, so anaphylaxis is a type of type 1 hypersensitivity reaction. Anaphylaxis, there will be swollen lips, there will be breathing difficulty also. Okay, breathing difficulty because of bronchoconstriction. Okay, anaphylaxis, there can be hypotension and there can be bradycardia. Okay, next, hives can occur, that is rashes, skin rashes can occur, and there can be allergic rhinitis also, and we usually use skin prick test for this. Okay, anaphylaxis is a life-threatening condition, requires immediate administration of IM, intramuscular adrenaline. Okay, adrenaline at a concentration of 1:10,000, 1:1000. Okay, this is the concentration. Okay, so this is about type 1, immediate, very quick. Prototype is allergy and anaphylaxis, those are the prototypes. Okay, and we use skin prick test for type 1. Now next is type 2 mediated. Type 2 hypersensitivity reaction is nothing but, the major mistake which everyone makes is, it is not, even though it is called cytotoxic, okay, it is known as antibody dependent cellular cytotoxicity. Okay, ACC. So even though it is called cellular cytotoxicity, it is not mediated by T cells, it is mediated by B cells which produce antibodies. So basically what happens is, anytime an allergen or something, anytime these antibodies, no, they will, these antibodies which are basically IgG or IgM, they will sit on these cells, maybe RBCs or maybe other cells also. Okay, so and it causes complement mediated activation. This membrane activation complex is formed. In this case, in case of RBC, here what we are saying is autoimmune hemolysis. Okay, autoimmune hemolysis. Okay, so basically these antibodies are sitting on these cells and they are causing its destruction. Okay, so then it is phagocytized by the macrophage. Okay, so common example is like transfusion reaction. Okay, whenever blood transfusion is given, if there is mismatch, it causes hemolysis, right? Because there is circulating antibodies against the wrong blood group. Okay, so that is type of type 2 mediated hypersensitivity. Similar examples are Goodpasture syndrome, where antibodies are mediated against kidney and lungs. Okay, in Goodpasture, and similarly in rheumatic heart disease, where there is valve damage because of this molecular mimicry. Okay, so this takes place from hours to days. Okay, it is not as immediate. Third type is immune complex mediated, where actually immune complex, say this is the like the allergen. Okay, and sorry, this is the foreign molecule. Okay, and against this there are antigens. Okay, so these are soluble antigens and then these are soluble antibodies. Okay, so they form soluble immune complexes which gets deposited in this endothelium. Okay, and on the endothelium it will get attached to the basement membrane and it causes this immune complex mediated deposition. Okay, these immune complexes are deposited in this vessels. Okay, causing causing tissue damage because these mediators are released. Classic example is vasculitis. Okay, vasculitis is a classical example for this, and other autoimmune diseases like SLE. Okay, SLE is an example, vasculitis is an example of this, and here you can see fibrinoid necrosis also. If you remember 2-3 chapters before, we had discussed this also. Now what is a prototype of this? This is serum sickness, where you can see rash, fever and joint pain, called as serum sickness. And if it is localized to one particular area only, this type 3, then it is known as Arthus reaction, where you can see localized skin ulcer. Okay, so this occurs over days to weeks, a little bit longer than this type 2 hypersensitive reaction. Okay, and the most important one is type 4 delayed, which is mediated by T cells. Okay, so far it was mediated by, type 1 was mediated by mast cell, type 2 and 3 was mediated by B cell, and now type 3 is type 4 is mediated by T cell. Okay, so in T cell, simple antigen presenting cell will be there which will grab this antigen and it will activate this T cell, which causes activation of Th1 and Th17. In previous slide also we saw Th1 and 17 are related to autoimmune diseases. Okay, which releases cytokine, especially interferon gamma. Then it causes macrophage activation and T cell activation, and it causes granuloma formation and all. Okay, so this is basically delayed. Okay, so it is seen after 48 to 72 hours. And TB skin test is an example, which is this is nothing but MAN2 test. MAN2 test is an example of type 4. Okay, similarly contact dermatitis, like any irritation caused because of some contact with some irritant, that causes contact dermatitis. Example is poison ivy rash. Okay, this is also example for type 4. Similarly granuloma formation in TB is also type 4. Okay, so One more important thing is this type 4 inflammation, this is only related to memory cells. Okay, in other inflammation, in other hypersensitivity, memory T cells are not activated. Only in this memory cells are activated. So the memory activation is only happening in type 4 hypersensitivity. Okay, I think I have covered almost everything. So let's solve questions. Timing, type 1 occurs within minutes. Okay, minutes to hours, and type 4 occurs within days, that is after 24 to 72 hours. Okay, complement activation, see, very important. I think I missed this part. No, I had explained this also. See here in type 2, once these antibodies are deposited on this antigen, after that there is complement activation, right? So complement activation is seen in type 2. It is also seen in type 3, where there is antigen antibody complexes deposited. Okay, so this is seen in type 2 and type 3. That's why in SL you can see this complex depositions. Okay, memory T cells are seen in only type 4. Okay, memory dependent is only type 4, others are not memory dependent. Type 3 prototype is serum sickness. Okay, so this was seen in previous days when they were giving some serum, like anti-horse serum or anti-tetanus serum. That time the body used to recognize it as some foreign antigen. So this foreign antigen and antibody used to deposit in the blood vessels, causing type 3 hypersensitivity. That's why we call it as serum sickness. Contact dermatitis is a form of type 4. Which is localized type 3, Arthus reaction. Okay, Arthus reaction. TB skin test, which type? Type 4. Immune complex mediated is type 1. IG mediated, what is IG mediated? IG mediated is again type 1. Sorry, here immune complex mediated is type 3. Okay, type 3. I don't know if you are watching this video with attention. Okay, so this is type 3. So if cytopenias occur, remember cytopenia means hemolysis. Okay, some cells are being broken down. Hemolysis, we saw which example? Type 2. If granulomas are occurring, then which it is? Yes, very good, type 4. So allergy testing evaluates which type? Allergy testing, skin prick test we are using for type 1. Okay, so now I think you are not going to forget this. Okay, because image based memorization makes it much easier. So next we'll go to immunodeficiency disorders. So immunodeficiency disorders, basically it is failure of the immunity to eradicate this, clear of the microorganisms. Okay, so it can be two types. Primary, where the cause is some genetic or some underlying defect already. Secondary is where there are other causes, okay, other than primary. Like for example, in HIV, in chronic steroid use, okay, chronic steroid use, because steroids are immunosuppressants. Okay, chronic steroid use. There can be bone marrow suppressions. Okay, in case of leukemia also it occurs, in case of radiation. So there are n number of causes for this. Okay, but most important thing that you should concentrate is one is HIV and chronic steroid use. Okay, so it's a primary and secondary. So in primary, when it is like related to some genetic cause or some other defect, there can be 3-4 types of defect which you need to remember at this point of time. One is B cell defect, which means B cells are defective, hence it is not able to clear off microorganism. Now remember that this B cell defect causes recurrent bacterial infection. So B for B. Okay, so B cell means recurrent bacterial defect. T cell means viral and fungal infections. Okay, so that is how you need to remember. There are some diseases like SCID where there is combined. Combined means both B cell defect is also there, T cell defect is also there. Okay, so now bacterial defects, bacterial infections such as Streptococcus, Staphylococcus, all these will be more common in B cell defects. In T cell defect, there will be herpes, candida, such infections will be there. Okay. So now there are third type of immunodeficiency where there is phagocyte defect. Phagocyte defect means especially macrophages. Okay, so what happens is, one of the classical example for this is CGD, which is chronic granulomatous disease. What happens in CGD is, inside the macrophage there will be inside the neutrophils. Okay, basically neutrophils, there will be something known as oxidative burst. Oxidative burst means when phagosome, like it has to kill the phagocyte, it has to kill microorganism, no? So it has to produce more of reactive oxygen species. Okay, now for this NADPH oxidase enzyme is required, and this is defective in case of CGD. Okay, CGD is a defect lies in this enzyme, so reactive oxygen species are not produced, and hence there is no increased reactive oxygen species, so killing of bacteria doesn't happen. Okay, and this killing of bacteria is especially catalase positive. That's why staph infections, okay, staph infections are more common in case of catalase positive infections are more common in case of phagocyte defect. Okay, also we can see one more infection, that is aspergillus in this case. One differential diagnosis of CGD, which is commonly asked, which is related to this phagolysosome fusion, that is Chidiac Higashi syndrome, okay, CHS we call, where we'll find albinism and platelet defect also, okay. So in Chidiac Higashi syndrome, there is a defect in the LIST gene, okay. So there is no fusion of this lysosome and the phagosome, which that is bacteria when it is engulfed into the lysosome, which carries this lytic enzymes. So there is no fusion because of this LIST gene defect, as a result of which there will be immunodeficiency, okay. So these two things you need to remember, okay. Now there can be one more set of defect known as complement defects, where C5 to C9 deficiency occurs, and it is seen in case of Neisseria and meningococcus, okay. So remember, Neisseria and Neisseria, that is meningococcus is nothing but Neisseria meningitidis, okay. So Neisseria infections are prone in case of C5 to C9 deficiency, okay. So there are actually total 10 types of immunodeficiency disorder according to latest classification, and you don't have to go through depth for everything, okay. So all these things I think, okay, in case of immunodeficiency disorder, how do you proceed? So history will be recurrent infections will be there, okay. Then you will find what is the infection pattern, whether it is bacterial, viral, fungal, or whether it is combined, okay. Then after that you will see in lab values you will see immunoglobulin levels, whether there is low immunoglobulin levels, which means it is a B cell defect, whether it is lymphopenia, whether there is T cell deficiency or whether there is B cell deficiency, and whether antibodies are present or antibodies are absent. You will see antibody levels of IgA, IgA, you will see IgM, you will see IgG, okay, you will see IgE, okay. So all these levels will be assessing, okay. These are immunoglobulin levels, okay. Next, we'll classify whether it is a B cell defect, T cell defect, phagocyte, or complement, and then we'll give therapy. I'll discuss shortly about therapy also, okay. Now, some specific syndromes. So if in a small child, in an infant, okay, very early, okay, severe early infections, which are both bacterial, fungal, viral, all are combined, then we'll call it as SCID, okay. SCID is one which you should know because there is gene therapy available. This was the first disease for which gene therapy was available, okay. Second type of disease is Job syndrome, where you can find increased levels of IgE, and there is cold abscess also. See, cold abscess means these are not like tubercular abscesses, okay, like they are not painful, and they don't show signs of inflammation, okay. So that's why they are known as cold abscess, okay. Now this is known as Job syndrome. Now why Job? Because there is a character in Bible where this person got many boils, many like abscesses on his skin, okay, because there is a big story behind it, okay. So that's why that character is named after this syndrome. Third important one is leukocyte adhesion defect. So this is type 1, okay, type 1, where this, if you had watched the part 1, you will remember there is defect in beta 1 integrin, okay. What are integrins? Go back and watch. I think it was number 1 module, that is acute inflammation, okay. So in number 1 chapter we had studied about leukocyte adhesion defect, okay. So there is delayed suppression of umbilical cord, that is after 30 days, okay. And then C1 inhibitor deficiency that causes hereditary angioedema. So these are some of the most common questions that are asked. One more I want you to remember is DiGeorge syndrome, okay, where there is T cell defect and there is absent thymus. Okay, absent thymus with T cell defect. It is also known as velocardiofacial syndrome, and there is catch22 mutation. Okay, catch22 in 22nd chromosome. Okay, and okay, and you can also find a cleft lip, cleft palate also in this, cleft lip and palate with congenital heart disease. Okay. So these are some of the things that you should be knowing side by side. Okay, some of you might feel that what kachra I am making on this notepad, like I am writing everything here and there, it is so haphazard, it is not clean, because some faculty will say no, everything is clean, they will write everything properly. See, I am a person who believes that preparation, okay, for exam, especially for NEET PG, is all integrated. It is not like you go from one direction and you end up in the other direction. No, it is all integrated. So I like doing integrated things. I like connecting things. I like bringing one connection to other. Okay, so that's why my handwriting may be and presentation may not be good, but what you take out of this video, what you take at the end of this class, that is more important. So what is this defective oxidative burst? It is seen in CGD, okay, chronic granulomatous disease, and we use a test known as nitro blue tetrazolium test. Okay, nitro blue tetrazolium test. So what happens is, normally if oxidative burst is there, this nitro blue tetrazolium will convert cells into blue color. Okay, so that is normal. Okay, if it doesn't occur, then it is an indication of CGD. But confirmatory test for CGD is something known as DHR, which is dihydrorhodamine. Dihydrorhodamine test. What is it and all, you don't have to remember right now. Okay, so it is dihydrorhodamine test. So very important, whenever there is a T cell deficiency, T cell defect, genetic T cell or inherited T cell defect, live vaccines are contraindicated. Okay, remember this. Live vaccines like polio, measles, okay, all these are contraindicated in cases of T cell defect. In SCID, we need early transplant because infection is very early and then child will be susceptible. These babies are known as bubble babies. Okay, bubble babies, because you might have seen some movies and all where child is within that bubble only, because if they come out they'll be prone to infection. Okay, we use prophylaxis, especially cotrimoxazole. Okay, cotrimoxazole prophylaxis, we use cotrimoxazole is cotrimoxazole, okay, which is sulfa trimethoprim and sulfamethoxazole. Okay, so we'll go towards solving questions. Okay, combined dash, which combined deficiency causes severe early infection? It is SCID. Okay, phagocyte defect is CGD, chronic granulomatous disease with defective oxidative burst. Complement deficiency is seen in Neisseria infection. Complement deficiency leads to Neisseria infections. Okay, genetic X-linked A gamma globulinemia. So what is X-linked A gamma globulinemia? Basically, this gene which is present on X chromosome, which produces gamma globulins. Okay, gamma globulins is absent. Okay, so what are immunoglobulins? Immunoglobulins are basically gamma globulins only, so that itself is absent, so there are no antibodies produced, there are zero antibodies. So this condition is known as X-linked A gamma globulinemia. And I told you, whenever there is B cell defect, no antibodies, which infection are they susceptible to? Bacterial infections. Okay, so this occurs in Bruton kinesin BTK mutation. Okay, we call it as Bruton tyrosine kinase. Okay, Bruton tyrosine kinase. This gene is defective in X-linked A gamma globulinemia. What is the treatment? Treatment is we give prophylaxis, we do stem cell therapy. One more treatment that we give is IVIG. Okay, this IVIG is to protect against infection. Okay, and this is mainly given, one basic disease which we have not talked about is CVID, that is combined variable immunodeficiency. So a short note about this combined variable immunodeficiency, this occurs later in the life. Okay, especially during childhood. Okay, and they will be susceptible to bacterial and viral infections. Okay, bacterial and viral infections. And it also presents with hepatosplenomegaly and lymphadenopathy. Why all this occurs, you don't ask me. Okay, and in this case we give CVID. Okay, it mainly presents as diarrhea also. Okay, it is associated with diarrhea also. Okay, so next, which syndrome is associated with increased IgA and cold abscess? It is Job syndrome. I told you about Job. Delayed umbilical cord separation is seen in LAD1 defect. Okay, LAD1. Next, absent thymic shadow is seen in Dye-George syndrome, where there is a T cell defect. Okay, T cell defect. If fungal and viral infections are present, it is which cell problem? If fungal and viral are there, it is T cell. If pyogenic, yes, very good, yes, it is B cell. Okay, if nitro blue fails, okay, if nitro blue is positive, then it is normal. Okay, that is blue color is there, it is positive, it is normal. If it fails, then it is nothing but CGD. Okay, that is oxidative burst is absent. Okay, that's it. I think you will get all information from this one specific this one only to solve MCQs. All headings mentioned here are nothing but keywords used in the MCQs. Okay, next we'll go to this hypersensitivity reaction. Is again actually a repetition, it was by mistake, so just cross it over, and we'll go to rheumatoid arthritis, the pathology part. So pathology part of rheumatoid arthritis. Okay, I discussed earlier, there is always an underlying genetic risk. In rheumatoid arthritis, rheumatic fever is entirely different. So this is in the form of DR4. Okay, remember DR4 is for rheumatoid arthritis. B27 was for HLA B27. HLA B27 was for ankylosing spondylosis. Okay, so here it is DR4. So along with this genetic predisposition, when there is a trigger, and here most common trigger is smoking. Remember, smoking is the most common trigger for rheumatoid arthritis. So why is smoking so important? We'll go through this. Okay, so what happens is when smoking happens, it causes something known as a citrullation. Now what is citrullation? Citrullation is conversion of this amino acid. Okay, so initially it is arginine, it gets converted into citrulline. Okay, and this occurs with the enzyme known as PAD enzyme, which is nothing but peptidyl arginine deaminase. Okay, peptidyl arginine deaminase. This enzyme actually causes citrullation, And when citrullination occurs, it is perceived as this peptide protein, which happens because of the citrullination. This is perceived as a foreign body by the body, and it generates antibodies, autoantibodies against this citrullinated proteins. Okay, this is known as anti-CCP. Okay, anti-citrullinated protein antibody. Okay. Okay, this is known as anti-CCP. So these are the most specific antibodies against rheumatoid arthritis, most specific. Okay. Other type of antibody which we see are RF antibody. Okay, rheumatoid factor antibody. Okay. So this is about smoking. Now, once autoantibodies, anti-CCP and RF are formed, these antibodies will cross-react with the synovium. What is synovium? It is a layer surrounding the articular cartilage. Okay. So once this inflammation starts, then it starts inflammation process. Okay, Th1 and Th17 are activated, as we had seen in last image, and this causes activation of cytokines TNF alpha and IL-6. Okay, I'll tell this why it is important. Okay, and then these bring other inflammatory cells, neovascularization occurs, granulation tissue occurs, that is known as pannus. And this pannus or granulation tissue along with neovascularization corrodes this cartilage. Okay, and it causes all the symptoms of rheumatoid arthritis, that is cartilage and bone erosion and joint deformity, and like joint deformity occurs, and then there will be so much inflammation that is taking place. So what are the common clinical symptoms? Symmetric small joint involvement. Remember, symmetric means it should be bilateral and it should be small joint involvement, especially metacarpophalangeal joints. Okay, metacarpophalangeal joints and proximal interphalangeal joints. Distal interphalangeal joints are not usually involved. Okay, and this wrist joint is also one of the earliest joint to be involved. Remember, DIP, distal interphalangeal joint, this joint. Okay, this joint is not involved. Okay, proximal interphalangeal joint, metacarpophalangeal joint, and wrist joint can be involved, but DIP is not involved in case of rheumatoid arthritis. And the most common symptom is early morning stiffness, which means after waking up, patient will feel stiff joints for almost more than 1 hour. Okay, after waking up. There are some extra articular manifestations also, which are basically rheumatoid nodules on the skin, which are painful nodules, especially on the extensor surfaces. It can also cause vasculitis symptoms, and it can also cause lung disease, especially interstitial lung disease. Okay. Now, on microscopy, what you'll find? You'll find pannus formation, you'll find so many inflammatory exudates, okay? And you'll find something known as swan neck deformity. What is swan neck deformity? This deformity is swan neck deformity, where there is hyperextension at proximal interphalangeal joint and there is flexion at distal interphalangeal joint. Okay, so this is swan neck deformity, which is in a rheumatoid arthritis. Okay, now what extra things you need to know? One is DR4, okay, next anti-CCP, and then what is pannus formation, okay, and then it is symmetric. Symmetric, same side, small, stiff synovitis, okay, and two inflammatory mediators are TNF alpha and IL-6. That's why in normal disease we use early DMRD. Now what is DMRD? DMARD, okay, DMARD means disease modifying anti-rheumatic drugs. Okay, so disease modifying anti-rheumatic drugs, and best example for this is methotrexate. Methotrexate is the best example for this. Okay, and then we have TNF alpha inhibitors like infliximab. Okay, we have adalimumab. Okay, and we have certolizumab. Okay, certolizumab, and IL-6 we have tofacitinib. Okay, tofacitinib. Sorry, it is not tofacitinib. Sorry, it is tocilizumab. Okay, I always get confused between this. Okay, tocilizumab. Okay, so this is basically therapy of rheumatoid arthritis. So let's see the MCQs. HLA, which association? HLA DR4. Okay, what is the trigger? Trigger is smoking. Smoking promotes citrullination, and this citrullination causes activation. This citrullination occurs because of activation of which enzyme? PAD enzyme. Okay, PAD enzyme, and as a result of which anti-CCP antibodies are produced. Now cytokines which are involved: IL-6 and one more is TNF alpha. Yes, TNF alpha and IL-6. Next, Th1 and Th17 cells predominant. Okay, what appears before symptoms? Anti-CCP occurs before symptoms. It appears in the blood. Okay, which enzymes drive citrullination? PAD enzyme, which is nothing but peptidyl arginine deaminase. Okay, which is the most specific marker for rheumatoid arthritis. It is anti-CCP only. Okay, characteristic of rheumatoid arthritis is pannus formation. Pannus is very characteristic. Okay, early disease modifying anti-rheumatic agents, they are they decrease the damage. And for refractory RA we use TNF alpha inhibitors, okay, and IL-6 antagonist. Okay, so this is all about rheumatoid arthritis you need to know from pathology. Now next 2 slides will be based on SLE alone. From pathology point of view, SLE, you should know about what are the risk factors and what is the pathogenesis and how it contributes to symptom complex. Okay, so basically, as any other autoimmune disease, the fact lies with genetics. Here it is HLA DR2 and DR3. So we had seen HLA B27 in ankylosing spondylosis. We had seen HLA DR4 in rheumatoid arthritis, and DR2-3 we are seeing in case of SLE. Okay, SLE is DR2 and 3. Along with the trigger is actually either it is UV light from the sun exposure, or it can be some infections, or it can be female. That's why there is estrogen. That's why there is 9:1 ratio of SLE occurring in female compared to male. Now basic pathology is loss of tolerance. So what is loss of tolerance? See, body has ability to identify which cells are self and which are not. So if this ability is known as tolerance, so this tolerance is lost. And second, these apoptotic cells, no, they are supposed to be cleared immediately. This apoptotic cell clearance is also lost. As a result of which, apoptotic cells DNA and all are exposed to our T cells, and their antibodies are produced against these nuclear proteins. They are nothing but ENA, anti-nuclear antibodies. Okay. Now, there is one more factor that happens in SLE that is called as netosis. So what is netosis? Netosis is somewhere between, it is a different form of, it is not necrosis also, it is not apoptosis also, it is something different. Okay, so that is known as netosis, where actually nuclear proteins, so they form web-like structures. Okay, they form web-like structures, and against this antibody formation can occur. So netosis also contributes to SLE pathogenesis. Okay, so once these antibodies are formed, the most common antibody, the most sensitive is ANA. Okay, but it is not positive in all 100% of cases. It is positive only in about 95. There can be 5% of cases where ANA can be negative also. Okay, second antibody is dsDNA, okay, which is directed against the double-stranded DNA. Okay, so this is implicated in assessing renal severity. Okay, so when SLE affects kidney, what is the severity that we can assess using anti-dsDNA? If you're asked which is a highly specific antibody, then it is anti-Smith antibody. Okay, anti-Smith. Which cytokines are associated with SLE? They are basically interferon alpha. Okay, so interferon alpha is the main cytokine behind pathogenesis of SLE. Okay, so once these antibodies are released, they will combine with this antigen and it will form immune complexes. It will mediate type 3 hypersensitivity, and it will get deposited in the kidney, skin and vessels, and there it will cause inflammation. Okay, and along with this inflammation, it will consume all C3-C4. So C3-C4 level both will decrease. So this is a classical case where C3-C4 are both decreased. Okay, because in infections, in post-streptococcal glomerulonephritis and all, C3 will decrease, but C4 will be normal. Okay, but in SLE both will be decreased. Finally, this leads to kidney injury, skin damage, skin lesions. Okay, it can lead to hemolysis. All these things can happen in SLE. Okay, so what are the clinical features? One is kidney involvement, and kidney involvement we grade as lupus nephritis. Lupus nephritis has class 1 to class 6, and out of this, class 3 and class 4 are the most severe forms of lupus nephritis. Okay, most severe are class 3 and class 4. In skin, it can cause photosensitivity leading to butterfly rash. It can lead to discoid lupus, okay, discoid rash. It can lead to alopecia. It can lead to photosensitivity, and it can lead to malar rash. Okay, malar rash means it spares this nasolabial fold. Okay. Now, in hematological aspect, it can lead to cytopenia. It can cause anemia, it can cause leukopenia, it can cause thrombocytopenia, and rarely it can also cause thrombosis. Okay, thrombosis happens when there are antibodies against the against the phospholipid membrane. Okay, so it is known as antiphospholipid syndrome. Okay, this is what you are saying, antiphospholipid syndrome, which causes increased thrombosis. Okay, there the antibodies which are involved are APLA. Okay, APLA antibodies. So in the kidney, when you see under microscopy, all type of immune complexes are deposited. It can be IgG, IgM, IgG, all are deposited. So it is known as full house deposition, full house granular deposition in kidney biopsy. You will find low C3-C4 levels when there is disease flare. Okay, and treatment is basically steroids, and along with that we'll give immunosuppressant, which is hydroxychloroquine. Okay, so important thing in MCQ which should be noted is ANA negative doesn't always mean SLE is out, because 5% of cases ANA can be negative. Okay, in drug induced SLE, the most common antibody, more specific, is antihistone antibody. Okay, antihistone antibody is more specific in case of drug-induced SLE. Okay, and that's it. I think I have discussed almost everything. Let's solve questions. So genetics, actually DR2 and DR3 link will be there. Loss of tolerance and impact clearance of apoptotic cells are seen. Okay. Complement C3 and C4, there will be less complements. Okay, this levels will decrease because of its consumption. Next, cytokine is interferon alpha. Okay, class 3 and class 4 glomerulonephritis is the most severe form, and then steroids and immunosuppressants are used. So what contributes to antibody formation, autoantibody formation? Basically it is which unique process? It is netosis. Netosis is one unique process which contributes to antibody formation. What causes thrombosis in SLE? In SLE, there is thrombosis question. Okay, some brain stroke has happened or MI has happened. Then you have to think of APLA antibodies or antiphospholipid antibody syndrome. Now, podocyte injury explains what? It explains nephritis, glomerulonephritis, which occurs with this along with proteinuria. Okay, proteinuria and nephritis occurs because of podocyte injury. Okay. Now, low C3, C4 is seen in SLE. Now, very important thing is, see, if C3 is low, C4 is low, it is SLE. If C3 is low, C4 is normal, it is post-streptococcal glomerulonephritis. Remember this point. Okay. Next, anti-DHDNA correlates with renal severity. Okay. And what prevents flares? Hydroxychloroquine. So hydroxychloroquine will give, which prevents SLE flares. Okay. So next, in SLE only, we'll see some more aspects regarding to specific to pathology. So most of the things are repeated again, except for this is what I was talking about, full house granular deposits on immunofluorescence, and on histology, that is normal histology, with severe nephritis is seen as wire loop lesion. Okay, so here you can see this mnemonic also, which is given on the right hand side, wire loop lesion. Okay, wire loop lesion is seen in severe nephritis. Okay, so you can see here wire loop lesions. See here, there are wire loop lesions. Okay, so this is seen in severe nephritis in case of SLE. Okay. And next, one important factor I want you to focus is on this interface dermatitis. Can you see this? What is this interface dermatitis? Because of T cell mediated damage, this basal layers, no? This, see this basal layers. Here, this basal layer and between dermis and epidermis, there is inflammation. Okay, this causes interface dermatitis, and you can see some vacuolization also. There are vacuoles that are formed. These are known as colloid bodies. Okay. This vacuolization in this keratinocytes is known as colloid bodies. Okay, which type of necrosis occurs? Fibrinoid necrosis occurs. I think rest of the things are almost the same only. Okay, yeah, we have some extra things. In spleen, okay, in spleen arterioles, no, they will start degenerating. Okay, like there will be fibrinoid necrosis, and it will cause onion skin appearance of the spleen arterioles. And in heart valves, there will be deposition. Okay, this is non-immune, this is you'll find this immune-mediated valvulitis, that is known as Liebman-Sachs endocarditis. Okay, Liebman-Sachs endocarditis. It is non-thrombotic. Okay, it is non-thrombotic immune-mediated. Okay, non-bacterial thrombotic endocarditis. Okay, non-bacterial thrombotic endocarditis. Okay, I think rest of the things I have discussed already, so we'll go to the questions. Granular full house deposition is seen. Okay, granular full house. Low C3, C4 indicates acute SLE flare. Okay, means acute SLE disease activity. Kidney class dash proliferative glomerulitis is most severe, 3 and 4. Skin, what you see? You'll see interface dermatitis. Right? Yes, interface dermatitis. Fibrinoid necrosis is seen in the vessels. Okay. In heart, you will see Liebman-Sachs endocarditis. Okay. It is non-bacterial thrombotic endocarditis. Liebman-Sachs endocarditis. Spleen, you see onion skin arterioles. Okay. Dash lesions correlate with severe nephritis. Which lesions? Wire loop lesions. So wire loop. So basically the point behind using this PDF full of images is so that you don't have to mug up things. You'll remember, like when you see this image, this particular image, this SLE immunofluorescence image in your exam or in your GT, Definitely you don't have to think twice because it appears granular. Okay, so it is granular, okay, basement membrane type, and it is full of all these deposits, so directly you'll mark SLE. Similarly, this chicken wire lobe lesions, spleen arterioles, okay, interface dermatitis, so this shouldn't cause any confusion at all. Okay, so that's the point behind going through this image based discussion. Next we'll discuss a very important topic, that is amyloidosis. So amyloidosis is one topic where students often misunderstand. So amyloidosis is nothing but misfolded protein which accumulates in organs and causes organ dysfunction. So this idea should be basically clear. Now, which type of proteins? If you see this, there is protein, there are two types, alpha helical structure and beta pleated structure. So in this beta pleated, this is beta pleated structure. So beta pleated structure, there is some misalignment, misfolding that leads to fibril formulation. Okay, this aggregation of fibrils in the organ causes organ dysfunction, and that result is what we see as symptoms. So different types of amyloid proteins can get deposited. So basically amyloids are proteins only. So in case of light chains, like in plasma cell dyscrasia, where we saw module number 20 was plasma cell dyscrasia, where serum light chains, okay, there are many light chains that are produced. These are called as AL light chains, okay, sorry, light chains, okay. So these light chains can get deposited and form amyloid AL type, okay, and these light chains can cause amyloidosis. Similarly, in chronic inflammation such as, let's say, Crohn's disease or the inflammatory bowel syndrome or some other chronic pathologies, because of chronic pathology, liver releases increased SAA, okay. This SAA is nothing but serum amyloid A, okay. This is a normal protein, okay, but this protein, when they are misfolded, it gets aggregated into AA type of amyloid and it causes dysfunction, organ dysfunctions, okay. Similarly, in a genetic mutation which affects transthyretin protein, there is accumulation of ATTR amyloid leading to liver dysfunction. Similarly, in dialysis, there is accumulation of this beta 2 microglobulin which causes amyloid beta 2 microglobulin accumulation, which causes again dysfunction, okay. So macroglossia also occurs in AL type, which is actually a rare type, okay. So these are the major reasons behind amyloid subtypes and their presentation. Now, if it deposits in kidney, it causes nephrotic syndrome, it causes proteinuria. If it deposits in heart, it causes restrictive cardiomyopathy, okay, and it can deposit in other organs also. Basically, it's a multi-organ dysfunction syndrome, okay. Now, on pathology, what you can see, when you take biopsy, when you stain it with Congo red, it is positive for Congo red, okay, because this misfolded protein, they'll absorb this Congo red stain and they'll stain positive. And on polarizing microscopy, you'll find apple green birefringence, okay. Birefringence means, I have told earlier, when you pass polarized light, it will refract the light in two different directions, okay. It will cause birefringence, okay. So how to monitor therapy, one more diagnosis is using serum marker, that is serum light chain assay, okay. Cardiac involvement, that is restrictive cardiomyopathy, you can diagnose using cardiac MRI. There will be diffuse enhancement of cardiac myocardium, okay. Therapy is basically addressing the underlying issue. Few visual mnemonics to remember are like apple green is for amyloid, A for apple, Congo red, okay, see Congo red, amyloid AL, so these chains look like L, okay, AL, and then you have SCAA, that is serum amyloid A in chronic inflammation such as rheumatoid arthritis and all, okay. Now, light chain, which type of amyloid? AL. Chronic inflammation, SAA, okay, sorry, AA type of amyloid, okay. Kidney, what type of presentation you will get? Nephrotic syndrome, okay, because of proteinuria you get nephrotic syndrome. In heart you get restrictive cardiomyopathy. Serum markers are light chain assay, serum light chain assay, okay. ATTR amyloid from which mutation? Transthyretin mutation. Transthyretin, okay. Dialysis patients accumulate which type of amyloid? Beta 2 microglobulin type of amyloid. Macroglossia is noted in AL type, that is plasma cell dyscrasias, and DASH involvement predicts prognosis. Which involvement? Renal involvement, okay. Renal involvement is always bad for one more is cardiac involvement, which is bad, okay. I think I have covered almost everything related to amyloid. Next we'll go to atherosclerosis. Atherosclerosis is a small topic, okay. Basically what happens is the initiating factor is not some fatty acid like infiltration or maybe some LDL. All those are not the things. First initiation is endothelial injury. Always it is endothelial injury. Once this endothelium basement membrane is damaged, only then this LDL or this oxidized LDL will go inside and it will attract macrophages. There will be foam cell formation, because when this macrophages ingest this oxidized LDL, there will be appearance of foam cell. Okay, then this fatty streak occurs, fibrofatty plaque occurs. Okay, there is something covering this, the tunica intima gets narrowed down. Okay, and then the plaque rupture occurs, then thrombosis and other complications such as MI, if it is in coronary arteries, all this happen. Okay, so the first injury is endothelial injury, it's not some other fatty streak deposition and all, no. Okay, so once this occurs, so fatty streak is the initial earliest lesion. Okay, so earliest lesion is fatty streak. There can be other underlying risk factors like LDL, high LDL will be there, hypertension can be there, diabetes, smoking. All this lead to endothelial damage. Okay, once there is endothelial damage, there will be increased inflammatory mediators, especially CRP, and the most concerned are HSCRP. Okay, this has high cardiovascular predictability, risk predictability. Okay, now once a plaque is formed, there will be a fibrous cap covering it. Okay, and inside that there will be a lipid core. Now this can undergo thrombosis, it can undergo aneurysm, or it can undergo stenosis also. Most common location is the coronaries, followed by abdominal aorta. Now, is this fatty streak irreversible? No, it is reversible. Fatty streak is reversible. This can be reversed, but once fibrofatty plaque and everything is formed, then it is irreversible. Confusing medial calcification. Now, what is this medial calcification? There is something called as Monckeberg medial sclerosis. So here what happens is, there are two layers, no? There are three layers totally. So see, this is the, in a normal endothelium, this is the intima, okay, this is the tunica intima, and this is the tunica media. Whatever happens in atherosclerosis is in the tunica intima, but there is something called as Monckeberg medial sclerosis, where in the tunica media there is stiffness. Okay, here there is stiffness. So it is not similar to atherosclerosis, it is different, and it is less dangerous compared to atherosclerosis. Okay, now what are the other rare facts? There is something called as neovascularization, SMC migration, and sparing of veins. Okay, so basically, as you can see here, this is the tunica intima. Okay, and this is where the lipid core is. So at this junction, no, there is some vascularization that is happening, that is neovascularization. And this neovascularization is one of the most important cause for plaque rupture and plaque bleeding, internal bleeding. Okay, that further leads to thrombosis and all. Now, what is this smooth muscle migration? SMC smooth muscle. So basically what happens is, when this fibrofatty plaque is formed, no, this is tunica media. From here, the smooth muscles start migrating towards the intima. Okay, so this leads to the formation of this fibrofatty plaque. Okay, and third is atherosclerosis doesn't occur in veins. Okay, that is very important, except if any vein is used in during coronary artery bypass. If a graft like saphenous vein or some other graft is used, some venous graft is used, that vein can undergo atherosclerosis, but as such atherosclerosis doesn't occur in the veins. So now when LDL is high, because we know that oxidized LDL leads to all this fatty plaque and all this formation. So once LDL is more than 150, we'll have to start statins. Okay, hypertension should be under control, because hypertension causes endothelial injury and further aggravates this atherosclerotic plaque formation. Okay, and lifestyle modification. So I think I have explained everything in this. Let's go to question solving. Earliest lesion is fatty streak. Okay, fatty streak. Okay, fatty streak is the earliest lesion. Dash LDL is ingested by the macrophages. Oxidized LDL is ingested. Okay, dash correlates with risk. Inflammation dash correlates with risk. It is HSCRP. And what stabilizes plaque? Which drug? Statins. Statins stabilize plaque. So statins has such a protective role in atherosclerosis. Okay, next we'll go to degenerative pathologies. Okay, we'll see some degenerative conditions and their pathology part. A very short topic on degenerative diseases. So what is the cause of degenerative diseases? The simple answer is the accumulation of this reactive oxygen species. Whenever these reactive oxygen species are there, it damages protein, DNA, and it causes misfolded protein aggregate. Okay, all these are various mechanisms. What is the starting phase? Starting phase is telomere shortening. Okay, telomere. What is telomere shortening? See, these are the telomeres. Okay, they start to shorten. Okay, this shortening causes this telomere shortening starts apoptosis and indicates the cell that there is some extensive damage, so you have to undergo apoptosis. So these telomeres are the reason behind aging, and if you can find a way through which you can prevent this telomere shorten, you can actually reverse aging also. Okay, now so this reactive oxygen species accumulation causes protein DNA injury, causes cellular decline, and causes organ dysfunction. That is the process behind degenerative diseases. Okay, so one important organelle which is affected is mitochondria, because this mitochondria, when oxidative phosphorylation, that is ATP generation, is declined, that time cellular stress increases. Okay, because of which Many issues happen, like for example, cross-link of collagen is affected, okay, which causes stiffness in degenerative processes, okay. So age also contributes to degeneration process, and there is one important marker, that is autophagy. That is autophagy is an important marker of aging. When autophagy is decreased, so this autophagy is something like cellular dustbin, okay, so it clears things, okay. So when this autophagy is impaired, that time cells like misfolded proteins or some cellular debris accumulate, and it causes damage to the cells, okay. So there is one syndrome where there is premature degeneration process that happens, okay, and that is known as Werner syndrome, okay. There is something called as Werner syndrome also, okay. This is Werner, okay. Werner syndrome is nothing but MEN1, okay. Werner is MEN1, okay. This is how we remember, MEN, okay. Werner is premature degeneration. So one pigment gets accumulated whenever there is degeneration, that is lipofuscin, okay. And this can be asked as an image-based question also. So when organ-specific deterioration happens, what happens in the joints? It leads to loss of cartilage, causing osteoarthritis. Second is in heart, what happens? Lipofuscin accumulation causing brown atrophy of the heart. In muscles also start degenerating, it causes decreased muscle mass, sarcopenia, okay. So what are the things which drive away from degeneration? One is exercise, which decreases rate of sarcopenia. So exercise is very important. Second is antioxidant, which are present in fruits. And third is degeneration actually predisposes to chronic diseases. So that's why our aim, if you want to live longer, is to decrease degeneration, okay. So aging, which telomere shortening, okay. Telomere shortening accelerates aging process. Neurons, what accumulation in neurons causes degeneration? That is lipofuscin, okay. It's an accumulation is a marker, okay, not causing. It's a marker that aging is taking place or degeneration is taking place. What impairment accelerates aging? What impairment? Autophagy. I told you autophagy is required for regeneration and healing. What syndrome shows premature degeneration? Werner syndrome. Werner, okay, NER. What slows sarcopenia? Exercise slows sarcopenia, okay. So next we'll go to edema, a very basic concept again. So what are the mechanisms of edema? There are like two types. One is pitting edema and non-pitting edema. For pitting edema, it is transudative or exudative, okay. So transudative means you already know by now there is low protein, there is increased hydrostatic pressure, or there is decreased oncotic pressure. Exudative is because of mainly inflammation and increased permeability. There is protein-rich cloudy material which has accumulated, okay. Now, non-pitting edema also can result, okay. We'll see that in later part where here only it is there, okay. Non-pitting edema. So non-pitting edema can occur in mixed edema as occurs in hypothyroidism, okay, or it also occurs in mucopolysaccharide deposition, okay. Mucopolysaccharidosis, it occurs, okay. Non-pitting edema is also seen in a lymphatic obstruction. Non-pitting means when you are pressing your thumb for 30 seconds, after that there is no pitting, but there is gross visualized edema. That is because of lymphatic obstruction, or there is deposition of such materials which doesn't allow pitting, okay. So these two things you need to remember, okay. Now what are the mechanisms of edema? I think I don't have to go much in depth. So one is hydrostatic pressure is increased, like in congestive heart failure as a result of increased hydrostatic pressure. See, there are various mechanisms. One is if this is a blood vessel, there is increased pressure within the blood vessel, that is known as hydrostatic pressure increase. Second is protein is what binds fluid with it and doesn't allow it to seep outside. So this is known as oncotic pressure. So if hydrostatic pressure is increased or oncotic pressure is decreased, like in nephrotic syndrome or in ascites, okay, because their albumin is low, okay, in both these cases there will be fluid shift, okay, fluid shift will be there. And if it is complicated with the inflammation, okay, inflammation, then it causes exudative, okay, then it causes exudative type of edema. If it is only the permeability is affected because of hydrostatic and oncotic pressure, there is no leakage, then it will cause transudative, okay. Now, similarly, decreased oncotic pressure in nephrotic syndrome we have already discussed now. One more is lymphatic obstruction, I told, where it causes generalized edema also, okay. And this lymphatic obstruction can be seen in filariasis and surgery. Most commonly it is localized, okay. So these are the final target points for edema. So there can be intra-organ edema also, like for example, pulmonary edema, okay. Within the lungs fluid buildup can occur, okay. There can be like cerebral edema also because of cytotoxic or vasogenic, carcinogenic, especially when there is brain injury or there is meningitis or there is lesions within the brain. Okay, there can be cerebral edema also. So these are like separate sets which we are not discussing with respect to peripheral edema. Now coming to management, say for any edema, things are simple. One is if there is increased hydrostatic pressure, that is like in case of congestive heart failure, you give diuretics. Okay, diuretics will decrease the preload. If there is a decreased oncotic pressure, we give albumin infusion. Okay, and then for localized causes of edema, we use compression, as in lymphatic edema. Okay, so let's solve. I think there is not much to be solved here. Okay, one is non-pitting edema is seen in lymphatic obstruction. Okay, non-pitting edema is seen in lymphatic obstruction. And what is used to treat hydrostatic edema? Diuretics are used to treat hydrostatic edema. Okay, so I think I have explained almost everything which is there. Next we'll go for disorders of pigmentation, a more common dermatology topic. This disorders of pigmentation can be hypopigmentation or it can be hyperpigmentation. Okay, both these are possibles. Okay, now for that you should know what exactly gives pigmentation. You know, it is melanocyte. You know that it's melanocytes, but it is not direct melanocytes. Actually, melanin is synthesized by the melanocytes, but then it is transferred to keratinocytes. Okay, so melanocytes are present, keratinocytes are present in the basal layer of the epidermis. Okay, so melanocyte transfers these melanosomes to the keratinocytes. Okay, now, so melanin is made by melanocyte, transfers to keratinocyte. Now, how is melanin made? We require an enzyme for that, and that enzyme is called as tyrosinase. Okay, so tyrosinase helps in the conversion of, it converts tyrosin to dopa, and dopa after some steps converts into melanin. Okay, so this enzyme here is tyrosinase. Okay, so if there is tyrosine defect also, now this tyrosinase defect is seen in albinism. Okay, so here melanocytes are normal, but inside that melanin pigment is not synthesized, because melanin is not synthesized because there is tyrosinase defect. Okay, this enzyme defect. Now there can be absent melanocyte also. Now there can be some autoimmune process which actually targets this melanocytes. If these melanocytes are absent, no melanin, again there will be hyperpigmentation. This is known as vitiligo. Okay, autoimmune melanocyte loss. Now there is something called as melanosome transfer defect. That is, I told you, from melanocyte to keratinocyte transfer takes place. If this transfer is defective, it can lead to two syndromes. One is Griscelli syndrome and one is Chidiac-Higashi syndrome. Remember, Chidiac-Higashi, list protein defect. We had seen it in, yes, very good. Yes, we had seen it in primary immunodeficiency disorders. Okay, in primary immunodeficiency, the differential diagnosis was chronic granulomatous disease. Okay, now these are related to hypopigmentation. Okay, we'll see some hyperpigmentation things also. Okay, so ACTH is the reason for this melanocyte stimulation. Okay, so if ACTH is increased, as occurs in Addison's disease, okay, increased ACTH, this increased because in Addison's disease there is decreased aldosterone, right? Okay, so what happens is that because of this decreased aldosterone and decreased cortisol in Addison's disease, okay, from the adrenal gland, these are secreted in lower quantities, or so that's why there is feedback on the pituitary gland, and pituitary gland increases ACTH. Okay, there is increased ACTH as a compensated response. Now this ACTH is similar to MSH, which is melanocyte stimulating hormone, and this actually stimulates melanocytes. Okay, that's why there is hyperpigmentation as seen in Addison's disease. Similarly, estrogen related hyperpigmentation over face is known as melasma. Okay, melasma. And post-inflammatory, maybe after burns or maybe after some injury, melanocyte stimulation can occur. This is known as post-inflammatory melanocyte stimulation that can cause hyperpigmentation. Some drugs are also implemented in hyperpigmentation. Example is minocycline, which is asked in the exams, and other is UV, because UV also stimulates melanin production. Okay, one more concept is bronze skin, which occurs in hemochromatosis, where there is increased iron deposition in this body. So there also we'll see bronze skin because of this iron deposition. So there also we see hyperpigmentation. There are two important concepts in exam which students often gets confused. One is freckles and one is lentigo. So both are hyperpigmentation only. These are small, as you can see, these are small. So these are less than 5 mm. Lentigo is more than 5 mm. Okay. In freckles, melanin only increases in the cells, but number of melanocytes, the cells which secrete melanocytes, are the normal. Okay, so normal melanocyte count and increased melanin. But in lentigo, which are slightly bigger, this one, okay, so here you can see many number of melanocytes are also increased. These are melanocytes, see, they are increased. So many melanocytes are present along with increased melanin, okay. One more is Qbank spot. I think everyone knows about this. It is linked with the NF1, that is neurofibromatosis 1, and McCune-Albright syndrome. If you ask me, there are some 7 to 8 causes of Qbank spot, but these two you should remember for exam, okay. Now, what is required for hyperpigmentation? One is sun protection is essential, okay, protection from UV. Second, melasma treatment is with hydroquinone. Remember hydroquinone, okay. And vitiligo, we use phototherapy for treatment, okay. Now, tyrosinase defect causes albinism. Autoimmune loss of melanocyte is seen in vitiligo, and increased ACTH causes hyperpigmentation. I think your mnemonics are here. Go through the mnemonics and let's go to the questions. Melanin is made by melanocyte, transferred to which cells? Keratinocytes, okay. Next, albinism is because of which enzyme defect? Tyrosinase enzyme defect. So this tyrosinase is different to tyrosine hydroxylase. Tyrosine hydroxylase is involved in alkaptonuria, that pathway, okay. Tyrosine metabolism pathway. Tyrosinase is involved in both. Starting product is tyrosine only. If it is tyrosine hydroxylase, then it goes through one pathway. If it is tyrosinase, then it goes through melanin pathway, okay. Okay, what is estrogen related hyperpigmentation known as? Melasma, okay. Next, increased melanin, okay, but normal melanocyte count is freckles, okay, and the lesions are less than 5 mm. Increased melanocyte number and more than 5 mm lesions are known as lentigo, okay. Which drug can cause hyperpigmentation? I said for exam you remember minocycline, okay. Next, oculocutaneous albinism shows normal melanocyte count or decrease. It is normal only. The problem is what? Problem is the enzyme. Which enzyme? Tyrosinase. Qbank spot is linked to neurofibromatosis 1, McCune-Albright syndrome, okay. Dash causes bronze skin hemochromatosis. We discussed this also. Hemochromatosis. Treat melasma with the hydroquinone, okay. Done. So we'll go to the next topic, anemia, a simple topic, okay. So see here, anemia, when you classify anemia, okay, based on RBC indices, okay, RBC indices. What are RBC indices? MCV, MCH, MCHC. Based on these three, it can be classified into three categories. One is hypochromic, microchromic hypocytic anemia, macrocytic anemia, and normocytic, okay, normocytic. This is microcytic, okay. So for microcytic means the cell size is small, okay. So MCV, what is MCV? Mean corpuscular volume, that is the volume of the RBC. So this tells us if MCV is high, it is macrocytic. If MCV is low, it is microcytic, okay. So microcytic anemia occurs because of three important reasons, okay. One is iron deficiency, which you should never forget. Second is thalassemia, which is very close differential of iron deficiency anemia. And the third is lead poisoning, okay. These three things, how to differentiate, okay. We'll go through that, okay. So there are something called as iron studies, okay. And in this iron studies, we have mainly serum iron, we have TIBC, that is total iron binding capacity, and we have transfer in saturation, okay, transfer in saturation. So what happens in iron deficiency anemia? Serum iron is decreased because there is deficiency of iron. But when there is deficiency of iron, what is the body's response? Whatever iron it will get, it will try to bind it, no? It will try to grab it. So iron binding capacity is increased. Transfer in saturation, which means transfer in is basically stores of iron. So what happens to transfer in? Transfer in gets less. That is because stores of ions are less, only depleted. So transfer in saturation is decreased. Now what happens in thalassemia? Serum iron in thalassemia is not less because iron you are giving, okay, blood plus thalassemia patients will have blood transfusion also. Because of that also there is excess iron, okay. So in serum iron is either normal or it is increased. TIBC, that is iron binding capacity. See, the body has a lot of iron stores. So why it will hold on to more iron stores? So TIBC is decreased. Transfer in saturation, that is the ferritin stores that are there in the body, okay, transfer in saturation, that is increased, okay. Next, what happens in anemia of chronic disease, okay, means some inflammation is causing anemia like kidney disease or maybe some liver disease or some thyroid disease. So what happens here? Serum iron will be normal, okay, it will try to preserve iron, okay, body will try to preserve it. TIBC is also increased and transferrin saturation is also increased. Ferritin is also increased. Okay. Next, one more was lead poisoning. Okay. Lead poisoning is very similar to iron deficiency anemia, except in lead poisoning, what you will find is, you will find basophilic stippling. That is, basophils will have this stippling. See here. See this basophilic stippling. Okay, these are basophils with this stippling. Okay, this is seen in lead poisoning. Now, target cells, these are like cells like this. Okay, these are seen in thalassemia. T for T, remember, target for thalassemia. So this is about microcytic anemia. Okay, so you see microcytic anemia, there is low MCV, decreased hemoglobin synthesis. In iron deficiency, there is decreased ferritin and increased TIBC. This is what we had discussed. Okay, in thalassemia, we have broken globin chains. Now next we'll go to macrocytic anemia, where MCV is high, and this is because of impaired DNA synthesis. And here you have to remember one thing, that is vitamin B12 deficiency. Okay, vitamin B12 and vitamin B9 deficiency, that is folic acid deficiency, and you'll see this hypersegmented neutrophils. Now, normocytic anemia, most common cause, okay, for normocytic is, one is acute blood loss. Sudden, because of trauma, blood loss happens, that is normocytic. Then hemolysis occurs, in that also it can be normocytic. There can be other causes also, like aplastic and anemia of chronic disease. So these both are not normocytic. It is basically anemia of chronic disease, actually microcytic. Okay. So here there is increased ferritin and decreased TIBC. That is what I have told. Increased ferritin, see here, increased ferritin and decreased TIBC. Okay, decreased iron binding capacity. That is because body doesn't want to bind protein, because there is something called as hepcidin. Okay, hepcidin is there. Okay, remember hepcidin comes in play in anemia of chronic disease, where hepcidin doesn't allow to bind protein, bind iron. Okay, to like iron transporting protein. So that's why there is decreased iron binding capacity, because or else these iron molecules, iron atoms are used by the microorganisms to grow. Okay, that's why body doesn't allow iron binding. Okay, so there is decreased TIBC. Okay, now I think I have okay. There is something called as hemolytic anemia also. Hemolytic anemia, basically it is usually it is a normocytic anemia only. If it is chronic hemolytic, then we can get microcytic. Okay, why all this I can't explain you in this video. So hemolysis can be, basically hemolysis can be intrinsic or extrinsic. Intrinsic means there is some defect inside the cell. Okay, like for example in G6PD, enzyme deficiency. Okay, or pyruvate kinase. Pyruvate kinase is one more enzyme deficiency which causes intrinsic. Okay, similarly spherocytosis, where the RBC structure defect is there. Okay, spherocytosis. All these are intrinsic hemolysis. Extrinsic means something, antibody from outside is causing hemolysis. Okay, so this is extrinsic hemolysis, and this is seen in autoimmune hemolysis. Okay, so there is one more cause of hemolysis which is extrinsic. I told you extrinsic, but it is non-autoimmune. Okay, you have to remember one thing, which is non-autoimmune. Okay, so it is not related to autoimmune disease, but still extrinsic hemolysis occurs. This is Wilson's disease. Okay, Wilson's disease. So in autoimmune hemolytic anemia, what we are using is a test. We use a test. We call it as Coombs test. Okay, Coombs test. So if Coombs test is positive, it is autoimmune hemolytic anemia. If Coombs test is negative, then it is Wilson's disease. Okay, remember that much for now. There are some other complements which cause, they are called as cold agglutinins. We won't go much into depth with this. Okay, so when during medicine we'll see in depth with these topics. Okay, so this is what hypochromic microcytic anemia looks like. See, there is central pallor. Okay, see the central pallor. So this is hypochromic, and the cells are also smaller in size, so it is microcytic. See here, hypersegmented neutrophil with large RBCs. This is megaloblastic. Okay, now whenever you are getting any question on anemia, what is the first thing you will check? Is it MCV, or is it the cell size, or whether it is hemoglobin content? No, first thing what you check is what is the reticulocyte count. Okay, it is represented by reticulocyte production index. If reticulocyte production index is more than 2, or it is less than 2, if retic count is high, more than 2, that means that somewhere some breakdown is happening, which means bone marrow is trying to produce more reticulocytes to compensate for increased destruction of RBCs. Okay, so this means bone marrow is normal. If reticulocyte production is less, means even though there is anemia, bone marrow is not trying to produce increased RBCs. Maybe the bone marrow itself is the problem. So this occurs in aplastic anemia. Okay. After this, we go to the other classification based on MCV. Okay, so first check reticulocyte count and see whether the bone marrow is responsive or not. We check it based on bone marrow response. Okay, next, iron therapy should be given only when there is proven iron deficiency anemia, because if you give in thalassemia, what will happen is it will further aggravate thalassemia. That is because already in thalassemia the problem is not with iron, the problem is with defective hemoglobin structure. So more iron will cause more damage to the body. So for hemolysis, how do you know there is hemolytic anemia? There are two factors. One is LDH, which will increase in hemolysis because it is an intracellular enzyme. Next, second is haptoglobin. Haptoglobin will decrease, and third thing is bilirubin will increase. Which bilirubin? Indirect. But now I think you know that indirect bilirubin increases in hemolysis, direct bilirubin increases in hepatocellular causes or in obstructive jaundice. So what is this haptoglobin? So basically HB, free HB doesn't circulate in the blood. Okay, free HB is not seen because free HB is bound to haptoglobin. Okay, so what happens is when there is so much hemolysis, that there is so much intravascular hemolysis, means within the blood vessels only there is hemolysis, so that free HB is released. Now everything will whatever haptoglobin is there, it will bind to this free HB and haptoglobin levels will decrease. So that's why decreased haptoglobin levels signifies hemolysis. Okay, next, megaloblasts are related to B12 and folate deficiency and low ferritin. See, low ferritin means low iron stores. Low iron stores are only seen in iron deficiency anemia. Okay, so I think I have explained in depth regarding iron deficiency because anemia, because many questions are being asked from this. So iron deficiency, what happens to ferritin? Ferritin are the iron stores. Iron stores are less only, so this is decreased. What happens to iron binding capacity? It increases, no doubt. Okay, in anemia of chronic disease doesn't want you to bind iron, because if iron binding capacity is more, the iron goes to microorganism. Microorganisms will bind to it and it will cause growth of microorganisms. So iron binding capacity is less. And what happens to ferritin? Ferritin stores are more. So basically what happens in anemia of chronic disease is when iron is present in the blood, no, there can be microorganism also. Now microorganisms can use this iron and grow. So what will body do? Body will not keep any iron in the blood. It will try to store as ferritin. Okay, so ferritin is increased. Also, second thing is ferritin is an acute phase reactant. Okay, so that's why also ferritin is increased. Okay, so ferritin is increased, but body doesn't allow iron to bind. That's why TIBC is decreased. Okay, that's how you remember it. Next, target cells are seen in isocyte T. T is for thalassemia. Okay, next, basophilic stippling is seen in lead poisoning. Okay, next, haptoglobin decrease signifies hemolysis. Okay, so go through this again. If you haven't understood from here, please go through your respective chapter in your main video lectures of any coaching platform and understand this concept properly. Okay, this is basically a revision. Whatever I could possibly tell you in this limited amount of time, I have told you. Next, we'll go through HPV. Okay, very important questions come from this. So HPV, basically we had gone through squamous cell carcinoma. So we'll just brush up through this topic. So you know already that low risk are 6 and 11 and high risk are the teens, okay, 16 and 18, okay, which causes cervical cancer, anogenital carcinoma also. Okay, so no need to go through this. HPV infection, I have told you again, it is a double stranded DNA. Okay, most common contact is sexual contact for cervical cancer. Initially there is two expression, that is one is E6 and E7. I told you how to remember also. E6 for P53, E7 for RB. Okay, we had discussed all this. This mutation causes it to undergo dysplasia. We'll see coilocytes. See here, coilocytes. Okay, we have seen this already, and it causes dysplastic squamous epithelium with atypia. Okay, so we call it as CIN, carcinoma in situ. Cervical interepithelial neoplasia, and then it progresses to carcinoma. Okay, so this is gradual progression. Pap smear we used to detect. Okay, so E7 is for RB and E6 is for P53. You have to just remember that. Okay. Other things I think are already answered. So vaccination is very useful. So we have different type of vaccines which are available now, which we'll be seeing in PSM. Okay. So low risk are HPV 6 and 11. Okay. High risk are 16 and 18. E6 inhibits P53. E7 inhibits RB. Okay. And what overexpression is a surrogate marker? P16. Okay, we had discussed this also, I think, in our prior module. So all these are just a sort of revision for you. 68, this was by mistake. Okay, so we are trying to correct mistakes actually. So all this was done in a hurry, so we'll try to finish make it normal proper in the next upcoming edition. So Kaposi sarcoma, there are a few things I think you should know. Okay, one is basically it is a tumor of endothelial cells. Okay, endothelial cell tumor. It's a vascular tumor. Okay, vascular tumor. Okay. Now the origin of this tumor, these cells, whichever these spindle cells you are seeing, no, the origin of that is actually modified endothelial cells only, which are known as spindle cells. Okay, so these spindle cells are nothing but modified endothelial cells only. Okay, so whenever there is HHV8 infection, so very important, HIV is not the reason for Kaposi sarcoma. Kaposi sarcoma reason is HHV8, which is herpes virus 8. Okay, human herpes virus 8. It is not HIV. In HIV patient, this infection can occur. Okay, so once this HHV8 is there, this virus, no, it causes release of some latent proteins, which causes inhibition of apoptosis. So inhibits apoptosis, and gradually transforms endothelial cells into spindle cells. Now these spindle cells will arrange inside the endothelium, and it will cause slit-like spaces. Okay, so these slit-like vascular channels are histological hallmark of this Kaposi sarcoma. Also, there is angiogenesis because of VEGF. Now what will happen is there is slit-like spaces, there is blockage in the blood vessels, there is proliferation also. Along with this, there will be hemosiderin deposition due to extravasated RBCs. Okay, so all this gives a purplish brownish appearance to the tumor. Okay, so that's why we see it as red purple lesion. See here, gross lesion, Kaposi sarcoma looks like this. This Kaposi sarcoma has a tendency to spread also. Okay, it can spread to GI tract, it can spread to mucous also. On microscopy, this is what you see, slit-like vascular spaces, okay, containing RBCs, and these are the elongated spindle cells, which are nothing but modified epithelial endothelial cells. Okay, so red purple lesions, where are they seen? On oral mucosa, and you can see on skin, mucosa, GI tract also. And if it is in the GI tract, it can also cause the GI bleeding. Okay, now which are the types of Kaposi sarcoma? See, it is not always associated with AIDS. There are 4 types. One is classic type, which is seen in age-old people. Okay, second is endemic type, which is African type. Okay, and this is the most aggressive type also. Third is transplant type, and fourth is AIDS related. Okay, and when CD count is less than 200 in AIDS, that time we come across HHV8 infection and Kaposi sarcoma. Treatment is again retroviral therapy will be there. Along with that, we'll give chemo also, which you don't have to go in detail. Hemosiderin deposition is seen, I said, because of extravasated RBCs. HHV8 latent proteins doesn't allow the cell apoptosis to happen, and there can be lymphedema also. Okay. Now, one important differential diagnosis of Kaposi sarcoma, because of that purplish lesion, no? If one important diagnosis is bacillary angiomatosis. Now, what happens in AIDS-related Kaposi sarcoma is, you know that CD count will be less than 200 and neutrophil also will be low. But if neutrophils are high and you are seeing Kaposi-like lesion and there is history of cat scratch, then your answer won't be Kaposi sarcoma. It will be bacillary angiomatosis caused by Bartonella Hensley. Okay, so you should be careful in your MCQs. So I think I have explained all. Okay, so let's solve. Which cells are the hallmark? Spindle cells. Okay, spindle cells are hallmark. What is the therapy? ART plus chemotherapy. Okay, chemo also will use. What deposition is common? Hemosiderin. Okay, hemosiderin deposition is common. See, there is one important correction here. HHV8 latent proteins aids in cell survival. Okay, cell survival, not overall patient survival. Okay, if neutrophils dominate, then we'll think of bacillary angiomatosis. Okay. Okay, so if GI bleeding is suspected, we'll do endoscopy and we'll have to treat the lesion. Okay. Next, we'll go to mesothelioma. Mesothelioma is in link with asbestosis itself. Okay. So what are some extra things that you should know? One is asbestos, which we had not discussed. Okay. Asbestos exposure, you can see here, right? These are asbestos fibers, especially in the construction or shipping yards. Okay. So these fibers are common. They go into the lungs. They cause chronic injury, inflammation. After this, they cause mesothelium. What is mesothelium? This is the cell that lines the pleural layer. Okay, so there it causes mesothelial cell mutation. Okay, so it is commonly associated with BAP1 gene. Okay, BAP1 is associated with mesothelioma. After that, there is diffuse growth. You can see here, there is growth of this mesothelial tissue, and then it causes like it's like a jacket. Okay, it encloses the whole lung. Okay, it is known as rind, pleural rind. Okay. and then manifestations come. Most common is the pleural effusion which happens. Okay, so cause is asbestos, and there are two types of asbestos fibers. One is serpentine fibers, which are curly like fibers, which are low risk, and there is one more amphibole fibers, which are high risk, which are long fibers. Okay, so many of you think that mesothelioma is only limited to pleura. No, mesothelioma can also occur because of peritoneal. It can also arise from the peritoneal cells also. There it is around 10 to 20% cases arise from the peritoneum. Okay, now symptoms can be dyspnea, pleural effusion, and in case of peritoneal it can be ascites, weight loss, such manifestations can happen. Okay, now on histology, what you see is you see tubulopapillary epithelioid pattern and sarcomatoid pattern. Okay, so there are three types of basically mesotheliomas based on histology. One is epithelioid, where you'll find predominantly epithelioid cells. Second is sarcomatoid, and third is biphasic. Okay, where you can see mixture of both. Okay, so you will see spindle cells also, and you'll see tubulopapillary epithelioid pattern also. There is one important marker which I want you to remember, and that is calretinine. Okay, calretinine is used for diagnosis, and mutation associated is BAP1. Now you know that in asbestosis, these asbestos dumbbell shaped fibers are there. No, these asbestos fibers surrounded by iron, okay, iron and proteinaceous material that causes this bodies known as ferruginous bodies. And very important that in some cases you can also get Samoma bodies in case of mesothelioma. So just don't be panicked if it is Samoma bodies appear in mesothelioma keywords. Okay, it can happen. Okay, now diffuse thickening of the pleura causes is mesothelium. Okay, and if you see CEA negative, because CEA causes adenocarcinoma. Okay, adenocarcinoma or bronchogenic carcinoma, where you can see CEA is increased. But if you see CA is negative, then you should always consider mesothelioma in your diagnosis. These all things I have already told you. Now on imaging in CT, you will find diffuse pleural rind, which means pleural thickening, which is altogether it is enclosing this whole lung. Okay, prognosis is very poor for mesothelioma. Primarily it is palliative only. Okay, so we'll solve questions. Fiber is, which fibers have highest risk? Amphibole fibers. Okay, amphibole fibers have highest risk. Imaging, what do you find? You find diffuse pleural rind. Diffuse pleural rind is seen. Okay, marker, what positivity marker? Calretinine positivity. Okay, mutation, BAP1 mutation. Write down this in your notes. Ferruginous body indicate asbestos exposure. Okay, treatment is largely palliative. Okay, that's it for asbestosis. Next we'll mesothelioma. Next we'll go to Alzheimer's disease. So Alzheimer's disease pathology, from pathology aspect, there are only two things that you need to remember. One is amyloid and another is tau. Everything revolves around this only. So basically, what is amyloid? Basically, these are precursors of APP. Okay? APP is a precursor molecule, amyloid precursor protein. From that, because of this misfolding in Alzheimer's disease, okay, we get this A beta, mainly A beta 42, okay, that exact variant. This is accumulated in extracellular space and it causes damage to the neurons. This is one molecule. Second is this tau. Tau is a protein which helps in microfibrillar network, okay, in arrangement. But this is also hyperphosphorylated. So phosphates are extra in this protein. So it also loses its function and it forms intracellular tangles. So which is intracellular? Tau is intracellular. See here you are seeing, no? Which is extracellular? Amyloid beta, that is A beta is extracellular. Now because of this, what happens is there are some changes in the brain and this leads to decreased neurotransmitter, that is decreased acetylcholine. So this decreased acetylcholine is linked to Alzheimer's pathology. Okay, so basically there will be forgetting things and all. Okay, so you see here APP is a protein. Because of misprocessing of APP, we get A beta fragments, and this A beta fragments accumulate extracellularly, causing amyloid plaques. Okay, similarly tau is there separate, okay, which forms intracellular tangles. Okay, so this tau and amyloid, these both are pathogenic agents behind Alzheimer's. Okay, that leads to shrinkage of the brain, it leads to memory loss. All those things happen because of that. Okay, now genetically we have risk factor for ApoE4. Okay, so if you remember, if you are an Avengers fan, Marvel fan, you will remember Thor. Okay, Thor or Chris Hemsworth. he was detected to have ApoE4 deficiency, mutation. So he is at increased risk of getting Alzheimer's. Okay, so there can be familial Alzheimer's also, and these mutations are involved. I don't think it is necessary to remember, but you can remember as APP. You can remember amyloid precursor protein. PSN you can remember as senile. Okay, senile. Okay, senile, SEN. So that is how you'll remember. Okay, now if suppose there is an adult Down syndrome patient in MCQ who has developed some memory issues, then early onset Alzheimer's is seen in Down syndrome because this APP is present on chromosome 21. Okay, so Down syndrome are at early risk, but for that they should survive into adulthood. Okay, now on imaging, what you see hippocampal atrophy. Okay, so hippocampus is the main site of memory, so that starts shrinking. Now on this MRI, what you can say is you can see temporal lobe. See here, temporal lobe bilaterally, it is atrophied. Okay, so temporal lobe atrophy, and you can see plaques over here. Okay, plaques, these are the plaques. What are the complications? There is one major complication, something known as amyloid angiopathy. So in the blood vessels also amyloid get deposited, and it leads to increased risk of brain bleed. Okay, so intracranial hemorrhage can occur. Okay, so these are the amyloid plaques that you see here. All these are amyloid plaques, extracellular, and these are intracellular tau deposits. Okay, this is tau and this is A beta. Okay. Now, one important disease you shouldn't confuse it with is Lewy body disease. Lewy body disease is seen in Lewy body dementia. Okay, Lewy body dementia. Here, what happens is there is accumulation of alpha-synuclein. Alpha-synuclein. Okay, this is separate. We'll go through that also in the upcoming slides. So here also dementia occurs, but here deposition is different. Okay, in amyloid it is in Alzheimer's it is always A beta and tau proteins. So hippocampal atrophy signifies Alzheimer's. Adults onset Down syndrome suspect like in an adult patient with Down syndrome suspect early onset Alzheimer's, and low acetylcholine is related. So that's why acetylcholine esterase inhibitors, they are shown to be beneficial in Alzheimer's disease. So examples include rivastigmine, which we use. Okay, rivastigmine. We use donepezil. Okay, these are some and galantamine. So these are some acetylcholinesterase inhibitors which we are using in Alzheimer's. Okay, so this is to remember amyloid beta is extracellular, tau is intracellular, and it is unstable also. ApoE4 has increased risk, and decreased acetylcholine is linked to Alzheimer's disease. Now, early, which part of the brain involvement? Hippocampal involvement. Okay. Neurotransmitter that decreases is acetylcholine. Genetics, what increases risk? ApoE4. Okay. Mutations in ApoE4. What is the complication? Amyloid angiopathy. Okay. Next, APP on chromosome 21, that is risk of Down syndrome. Okay, so risk in Down syndrome. Okay, early onset Alzheimer's. Dash slow decline. What is used for slow decline? Acetylcholine esterase inhibitors we use in slow decline. What aids in confirmation? Actually, there is something known as amyloid PET, amyloid positron emission. This one. Okay, PET CT scan. Okay, so there we'll find, that is what I had shown you in this image. So this is actually amyloid PET, where you actually see plaques. Okay, I think I have explained everything. Next we'll go to pathogenesis of diabetes. Okay, briefly about pathogenesis of diabetes mellitus, especially focusing on type 1. Okay, so basically in type 1 there is insulin defect, that is there is deficiency of insulin, and in type 2 there is resistance to insulin. Okay, both of this will lead to hyperglycemia only, that is high blood sugar, leading to metabolic shift, whatever happens, that is lipolysis, gluconeogenesis increases, and finally leading to complication. Three main complications. One is retinopathy, nephropathy, and neuropathy, and other complications are acute complications of like decay. Okay, once decay or HHS is hyperglycemic hyperosmolar state. Once that comes into picture, then other complication can also be there. Okay, decay like cerebral edema, there can be increased risk for atherosclerosis and all that. Those are some late complications. Okay, so how does type 1 diabetes start? It is because of some autoimmune attack. There are mainly 4 antibodies which you should know about. One is GAD, that is anti-glutamic acid decarboxylase. Okay, anti-GAD. Second is anti-ICA, which is islet cell antibody. Third is anti-insulin antibodies, and fourth is anti-insulin antibodies is IAA, and IA2, that is insulinoma associated antibodies 2. Okay, these 4 antibodies will have to remember. Okay, so once this autoimmune attack happens, beta cells, okay, which are reason for secreting insulin, okay, that is the endocrine pancreas, that leads to insulin deficiency. Now what happens in type 1 is, along with insulin, this C peptide is also secreted. Okay, it is a part of insulin chain. Okay, pro-insulin. Now then this C peptide is cleaved. So since there is insulin deficiency, C peptide levels will also be absent. There is HLA predominance. Okay, we had seen in rheumatoid arthritis, DR3 was involved. In HLA-B27, it was ankylosing spondylitis. Similarly, we had seen for SLE, HRA, DR2 and DR3. Similarly, for diabetes mellitus, it is DR3 and DR4. Okay, acute complication is DK, where there is increased ketone synthesis. Okay. Similarly, for type 2 diabetes, what happens is there is something called as adipokines. These adipokines are leptin. Okay, one is leptin, the other is adiponectin. Okay, adiponectin. What happens is these leptin and adiponectin, these actually increase insulin sensitivity, which means they are helpful adipocyte hormones. Okay, but what happens in diabetes is there is resistance to these hormones, as a result of which insulin resistance develops. Okay, so even though insulin is there, there is resistance to this. Like even though circulating insulin is there, glucose can't be uptaken. Okay, so because of this insulin resistance happens, that is because once this insulin comes and sits on its receptor, no, after that it causes a GLUT4 translocation. GLUT4 is responsible for influx of glucose, okay, from the blood into the cell. But what happens is this adipokine resistance causes this GLUT4 to go inside the cell rather than on top of the cell. So glucose can't be absorbed even though there are increased level of insulin, there is increased insulin in the blood. Okay. Also, you'll note that since insulin is secreted more, C peptide will also increase. Okay, see, this is one of the examples where you differentiate type 1 from type 2. Okay, because in type 1, C peptide levels are not there. Next, beta cell exhaustion happens. Now, because of this beta cell exhaustion, what happens is there will be misfolded proteins that accumulate, and these are called as amyloids. Okay, so here also amyloid is implicated in type 2 diabetes, not type 1. Okay, and then incretin defect happens. So what is incretin defect? So there are two hormones, GLP and there is GIP. These are secreted by the gut only. So these help in for insulin to improve insulin sensitivity. Okay, but if there are defect in these both, the GLP and GIP, then it can lead to insulin resistance. Okay, so type 2 diabetes, most common complications HHS. Okay, type 1 most common complication is DKA. Okay, I think this mnemonics you can see here. There is pro-insulin, then it divides as insulin and C-peptide. Okay, so now because of this hyperglycemia and insulin resistance, there can be a syndrome that is known as metabolic syndrome. Okay, so in this what will happen? One, there is central obesity. Okay, second, there is hypertension. Third, there is insulin resistance. Fourth, there is dyslipidemia, and fifth, there is hyperuricemia. Okay. So beta cell dysfunction, it progressively declines over time in type 2 diabetes mellitus. Okay, so that you should know. And there is something called as a honeymoon phase which occurs in type 1. What happens is in type 1 diabetes mellitus, in beta cell there is loss, right? Autoimmune loss. So when we start giving insulin initially, what will happen is patient responds well, and whatever some beta cells which are there, no, still which are surviving, they will actually start secreting insulin because body's metabolic response is improved. So now what happens is patient's insulin demand decreases initially. Okay, so patient thinks that he has been cured of diabetes. So this is known as honeymoon phase. Okay, so many people they'll stop taking insulin. They will think they have been cured and they'll go for other alternative medicine. Okay, so that is where a clinician should be keen enough to counsel patients. Next, what is this glucotoxicity and lipotoxicity? Glucotoxicity means because of increased glucose, beta cell damage occurs. Okay, and lipotoxicity is because of increased fatty acid, this damage happens. Okay, because of this, the vessels which are affected are like the places which are affected are, one is retina, causing retinopathy, kidney, nephropathy and neuropathy. Okay, and then other organs are also affected because of chronic hyperglycemia. Okay, so anywhere you come across lean child with lean child, always think of type 1 diabetes. Hyperinsulinemia and insulin resistance, think of type 2. Okay, and low C peptide is seen in type 1. Also remember that there is something called as MODY, which is maturity onset diabetes of young. Basically, there are some defects in the enzymes in the glycolysis pathway, because of which glucose is not metabolized properly and there is hyperglycemia. These people usually present in adolescent and in early young adults. So any young adult presenting with diabetes, always think about MODY, and there will be always 100% family history of diabetes. Okay, and these people don't need insulin and all. They simple oral hypoglycemic agents, especially sulfonylureas are the drug of choice for this condition. Okay, so there are total 7 types of MODY. If you want, you can remember those. Most common type is the most favorable among this is type 2. Okay, next, which antibodies are positive in type 1 diabetes? GAD. Next, islet insulin antibodies, islet associated insulin associated 2, and islet cell antibody. Okay, these 4 are positive. What worsens resistance? Adipokines. Which are adipokines? There are 2 adipokines important, I told. One is leptin and another is adiponectin. Okay, next, adiponectin, which GLUT translocation is decreased in type 2 diabetes? It is GLUT4. Okay, GLUT4 transporter. Beta cell loss occurs resulting in what deposition? Amyloid. Okay, amyloid deposition in type 2. Next, HLA, which is linked to DR3 and DR4. C peptide is absent in which type? Type 1 it is absent. Incretin defect is seen in type 2 diabetes. Okay, it is not for type 1. Type 2, I told incretins are GLP and GIP. Okay. Okay, so we'll go to next, Parkinson disease, a very important topic. Okay, so from pathology point of view, there is only one thing which you should remember in Parkinson disease, and that is this alpha-synuclein. So what is alpha-synuclein? Basically, it is a presynaptic. Okay, so if this is the synapse, okay, so this is a presynaptic protein which is involved in signaling for dopamine. Okay, what happens in Parkinsonism is because of few factors. There are few factors because of which there is misfolded the synuclein protein. Okay, once it gets misfolded, then it becomes something known as Levy body. You can see here, right? Levy body. Now, once this Levy body is formed, there are other changes also that are happening, because of which this dopaminergic neurons in substantia nigra. So everything we are talking is with respect to this small area in the brain known as a substantia nigra. Okay, see, you can see here this substantia nigra. Okay, in the basal ganglia. So the substantia nigra has 2 parts, pars compacta and pars reticulata. Inside this pars compacta, we are getting to see this dopaminergic neurons which are involved in fine motor coordination. Okay, so motor coordination. So that is the role of this pars compacta, this dopamine present in this area. Okay, so what happens is, because of this substantia nigra, loss of dopamine in these neurons, of substantia nigra, the reason is because of this alpha-synuclein deposition. Okay, the misfolding of these proteins which causes alpha-synuclein aggregation, which is known as Levy bodies. Because of this, there is loss of this substantia nigra neurons, which leads to symptoms like bradykinesia, rigidity, tremors, the symptoms of Parkinsonism. Now, why this occurs? One is genetic reason. Genetic LRRK2 gene and Parkinson you will remember, but LRRK is one more gene which you will have to remember. Along with that, there is increased risk of pesticides. Aging is also a factor. Okay, and all this contribute to mitochondrial dysfunction. So in this substantia nigra dopaminergic neurons, this mitochondria complex 1, there are many ETC complexes in mitochondria. So there are 5 complexes. Out of this complex 1 dysfunction happens, because of which there is accumulation of reactive oxygen species which damages the neurons further, and slowly it causes degeneration of this dopaminergic neurons. Okay, so once there is loss of these neurons, dopamine comes down in pars compacta. There are 2 pathways, there is direct pathway and indirect pathway. Direct pathway is for stimulation of movement, indirect is for inhibition of movements. So this gets affected and all these symptoms come into picture. Okay, so this is a screen image of Levy body inside the neuron. See, this is Levy body. Okay, when you stain for alpha-synuclein, that time these Levy bodies are seen. Okay, Levy bodies are also seen in one more condition, that is Levy body dementia. Okay, if you remember Alzheimer's, I had said it there also. For Alzheimer's, the main molecules which are involved were A, beta and tau proteins. Okay, these are amyloid proteins. For Lewy body dementia, it is actually Lewy bodies. For Parkinsonism also, it is Lewy bodies. So you can see this substantia nigra, which should have been pigmented, it starts to depigment. Okay, so this is seen in Parkinson. Now there is one more thing that is known as MPTP toxin, which has been asked in question. This is also a reason for toxin induced Parkinsonism. Okay, it is not only age related, it can be toxin induced. If it is a young person, you should also think of a MPTP toxin. Okay, one more question which has been asked is, which is the earliest sign of Parkinsonism? That is olfactory loss. Okay, olfactory loss is the earliest sign. There are some other clinical features also other than this movement features. You will see some other non-motor symptoms, which are these are mainly anxiety, depression, okay, constipation. Okay, so there are many such symptoms. Okay, so these are known as non-motor symptoms. They precede the motor symptom, that is bradykinesia, tremors, rigidity. They precede them. Okay, and once you give levodopa, there is classic response in Parkinsonism, that is known as levodopa responsiveness, which actually has diagnostic value in Parkinsonism, and also you'll find autonomic dysfunctions features in Parkinsonism. Okay, so cogwheel rigidity and symptoms start unilaterally, think of Parkinsonism. Okay, so I think these are the short forms which you can use. We'll go to MCQs. Substantia nigra dash loss. Substantia nigra causes which part? Substantia nigra pars compacta. Okay, pars compacta. Substantia nigra pars compacta part is lost. Okay, neuron loss happens. Which protein aggregation causes Lewy bodies? Alpha synuclein. Okay, you shouldn't forget this. Genetic sites for LRRK1 gene. Okay, PARK gene anyways you will remember. Mitochondria, which complex dysfunction? Complex 1 dysfunction. Next, which toxin causes Parkinson disease like degeneration? It is MPTP toxin. Correct? MPTP, right? Yes, MPTP. What is the earliest loss? What is the earliest sign? Olfactory loss. Okay. Just the things are what I have discussed. Next, we'll go to renal failure, a very small topic. Okay, so basically in renal failure, you will have to differentiate between pre-renal, renal, and post-renal causes of renal failure. Okay, or nowadays we call pre-renal AKI, renal AKI, and post-renal AKI. Okay, so what happens is, if it is pre-renal, means the kidney is normal. Okay, the output from the kidney is also normal. Whatever comes inside the kidney, that is the blood and related things, okay, that is the problem. So it is basically a perfusion problem, which means the blood coming inside the kidney is so less that there is kidney damage because of that. Okay, so it is basically because of hypovolemia. It can be because of shock, it can be because of burns, it can be because of diarrhea. So anything which causes decreased blood volume to the kidneys causes pre-renal AKI. Now what happens in this? Urea and creatinine both rise. Urea rises because there is decreased volume, circulating volume. Creatinine rises because of AKI. Okay. Second is intrinsic, where the pathology is within the kidneys. You can see, this nephron itself is damaged. These tubules are itself damaged, or glomerulus is damaged. Okay. So these are seen in acute tubular necrosis. Some toxin or some drugs are causing direct damage to the kidney tubules. Okay, that is ATN. Next is glomerulonephritis, where glomerulus is involved. Okay, and third is interstitial nephritis, where the surrounding part around the glomerulus, okay, interstitium, that is involved. Okay, so these three are causes of intrinsic or renal AKI. Okay, and here you will see that creatinine increases very high, but urea doesn't increase in proportion to creatinine. Okay, next is post-renal. It could be because of obstruction, it could be because of some trauma, it could be because of bladder reasons like bladder cancer obstructing the flow, or it could be because of reflux, okay, or it could be because of kidney stones. So there is some pathology after the like the beginning of the ureters. Okay, some pathology outside the kidney that is causing the obstruction. Okay, because of back pressure there is AKI, that is called post-renal. Now what happens in AKI? Basically, because the kidneys are not able to excrete fluid, there will be fluid overload, and this leads to volume overload. Now what happens is, when fluid builds up in the tissues, it causes peripheral edema, But once it starts to build up within the lungs, it causes pulmonary edema, and this pulmonary edema is dangerous. That's in a patient with AK, if in the question you are given that on auscultation crepitations are heard, fine creps, pulmonary edema causes fine creps, then always think of pulmonary edema. One more reason is for this is one more differential diagnosis where you can see pulmonary edema, that is in congestive heart failure. Okay, in congestive heart failure also you will get pulmonary edema. So CKD, that is chronic kidney disease or acute kidney injury, renal failure, and CHF, that is congestive heart failure, these both are causes of pulmonary edema in MCQs, which you'll have to differentiate. Now electrolytes, hyperkalemia is seen. I think all of you know by now, hyperkalemia is the reason, is the electrolyte imbalance seen in kidney injury. That's why we always avoid potassium rich fluids, potassium rich IV fluids during kidney injury. Okay, next is which type of acid base balance do you see? You see metabolic acidosis, because kidney is involved in excreting acid, right? So it results in metabolic acidosis, and there are various other reasons also which I don't want to go in depth. One is uremia. Okay, uremia causes metabolic acidosis. Next, toxin accumulation. Because of this, there is uremia. Okay, uremia can cause metabolic acidosis. It can also cause something known as uremic pericarditis. When high uremia is there, it can cause uremic pericarditis, and it can also cause uremic bleeding. Okay, uremic bleeding. Okay. So how any insult that happens to the kidneys, okay, nephron dysfunction occurs, there will be decreased GFR, okay, then there will be uremic toxic accumulation, and then it will cause complications. Okay, so basically uremic pericarditis, there will be mineral bone disease, metabolic bone disease, okay, and then there will be acid base balance disturbances. So few important like microscopy finding that you should know from pathology point of view. One is muddy brown cast. You are seeing muddy and everything is brown. So brown you had seen somewhere else also, you had seen here, right? What was this image? This was direct injury to the tubules, that is nothing but EATN, acute tubular necrosis. So in acute tubular necrosis you will see brown color muddy cast. Okay, now epithelial cast means these are epithelial cells, nothing but epithelial cells. So there is some epithelial injury, tubular injury. So tubular injury causes epithelial cast. Next, WBC cast means there should be some WBCs, right? So in inflammation like pyelonephritis, okay, in pyelonephritis you'll see WBC cast. And then RBC cast means there should be some bleeding within. So mainly bleeding occurs in the glomerular only. So glomerular injury causes RBC cast. Okay, so there shouldn't be any confusion regarding cast. These four casts are the ones you should definitely remember. Okay, next, what is this FEN? FEN is nothing but fractional excretion of sodium, which means out of whatever sodium, okay, whatever sodium that comes into the kidneys, how much is excreted by the kidneys, that is a fractional excretion of sodium. Okay, now what happens in pre-renal and renal? This is FENA is used to differentiate between whether the EAK is renal or whether it is pre-renal. Okay, so what happens in renal is, in simple terms to understand, in what happens in pre-renal, I told you that if this is the renal blood vessel and this is the kidney, blood volume coming into the kidney itself is less. So body's compensative mechanism is to preserve as much sodium as possible, because the more the sodium body preserves, the more will be the blood volume. You know that, okay? Blood volume is directly proportional to how much sodium content is there, okay? So sodium retention means blood volume retention. So if body tries to preserve more sodium, then more blood volume will also be preserved. So what kidneys will do? It will not excrete. Okay, excretion of sodium will be decreased. So fractional excretion of sodium is less, that is decreased in pre-renal. Got my point? So fractional excretion of sodium is less than 1% in pre-renal. This is the best way to remember. Okay, next, okay. In chronic kidney disease, what happens is there will be fibrosis, there will be nephron death, okay, and slowly there will be alteration in the mineral density. That is, we term it as metabolic bone disease. Okay, so that is a separate entity. There, what happens is there is hyperphosphatemia. Okay, there is secondary hyperparathyroidism. Okay, these two features you will see. That we'll be discussing in CKD part of medicine. Okay. Next, this Vaxica, there is one more cast known as Vaxica. They are seen in chronic renal failure. That is one thing you need to remember. So here also see pre-renal cause. Pre-renal means perfusion reduced early. This is how you remember it. So there is no as per se kidney injury, but it is because of decreased perfusion. Next, ATN is acute tubular necrosis, muddy brown cast. Okay. That is how you remember. And then post-renal because of obstruction. Okay. So let's answer the questions. Electrolyte. Which type of potassium abnormality is common? Hyperkalemia. Okay, never take on hypokalemia. Next, acid-base balance. Which acid-base balance is most common? Metabolic acidosis. Okay, metabolic acidosis is seen in renal failure. Muddy brown casts are seen in acute tubular necrosis. Waxy casts in chronic renal failure. Okay, chronic renal failure. Hypoperfusion plus normal tables. What is this? Pre-renal AKI. Okay, pre-renal AKI. If fractional sodium is less than 1, which means body doesn't want to excrete sodium, it wants to preserve, which means the problem is pre-renal. So pre-renal AKI. Granular casts again are seen in ATN only. Okay, acute tubular necrosis. Next, dash inhibitors slow CKD progression. It is ACE inhibitors. Okay, ACE inhibitor. Why? Because the ACE inhibitors decrease proteinuria. Okay, this is one more concept which I don't want to explain because of time constraint. Next, we'll go to a small topic called tuberculosis. Next is about tuberculosis briefly. So basically it is because of inhalation. Okay, inhalation of droplets into the alveoli. Then there will be macrophages which engulf this bacilli. They remain dormant also. If immune response is mounted, then it will be via Th1 cells, T helper 1 cells. Okay, Th1. And then it will release interferon gamma. Remember, the whole story is behind interferon gamma. Okay, this interferon gamma will activate the macrophage. There will be granuloma formation, and then it can go under dormancy also. If immunity is good, it will stay in prison. Okay, that is inside the granuloma. Or if there is any within the macrophages, sorry, or if there is any activation of the bacteria, then it can cause cavitation in the upper lobe. Okay, so there is something called as primary TB and secondary TB. So secondary TB is basically reactivation which occurs in the upper lobe. See here you can see reactivation, it occurs in the upper lobe. Primary TB which occurs mainly in younger children, in infants and all, that remains in the lower lobes only. Okay, that is a primary site of infection. So granuloma, whichever is formed, it is basically caseating granuloma with central necrosis. Okay, I told you caseating granuloma, always remember TB. One more example is histoplasmosis. Now, initially when droplets enter, it is trapped inside the macrophages. Th1 activation happens, after which it releases interferon gamma. Interferon gamma activates the macrophages, and macrophages will engulf the microorganism. There shouldn't be any confusion regarding this. Okay, so after this what happens is it can either stay there only. Okay, it is known as Ghon's complex, that is primary site of infection with the hilar lymphadenopathy, where hilar lymph nodes are also enlarged. This is known as Ghon's complex. Okay, this initial where TB gets seeded, initial site of infection, that is known as Ghon focus, and along with hilar node it is known as Ghon complex, which is also known as primary complex. Now if immunity is less, or in children what happens is there can be hematogenous spread. Remember, TB doesn't go through hematogenous, doesn't spread through blood. If there is hematogenous spread, it will get seeded in various organs. It can go to the brain, it can go to lungs, other parts of the lungs, it can go to intestine, everywhere. Okay, and if there is hematogenous spread, this disseminated TB is known as miliary TB. Okay, miliary TB because on X-ray you can find it as small miliary pattern. Okay, millets like pattern on X-ray. Okay, that is known as miliary TB, and it is one of the most dangerous type of TB. So outcome is simple in case of TB. If immunity is good, it goes into latency, and if immunity is bad, then it will come out as active disease. So that's why since we health workers, doctors come across TB cases always. That's why we have popular saying among ourselves that TB is there within all of us. One day it will reactivate, and we'll all probably die of TB only whenever our immunity decreases. In the granuloma, you already know that there are giant cell, epithelioid cell, which are known as Langhans giant cell. Okay, there shouldn't be any confusion. Now, what is this? So what is this cord factor? So there is a molecule, there is a compound in the cell wall of the Mycobacterium tuberculosis, okay, bacteria, which is a virulence factor, which inhibits its phagolysosome fusion, that is known as serpentine growth factor or cord growth factor. I included this because this is something new, okay, which I didn't find in any books, might be asked in the future exams. Important about PPD is nothing but tuberculin injection which you give, okay, that is nothing but MAN2 test. So that doesn't tell you about prior sensitization. Okay, sorry, it tells you about prior sensitization. It is not diagnostic. It just tells you that somewhere the patient was prior exposed to TB. Maybe the TB is latent within his system, but he has this immunity also. So that's why in cases of immunodeficiency, and in case of HIV, you won't get MAN2 positive even though the person is exposed to TB. That is because there is no immunity to mount only. You know that this PPD, that is basically a type 4 hypersensitivity, and for type 4 hypersensitivity to take place, you should have a good immune system. If you don't have immune system, PPD won't be positive. Also, if the person is not exposed, then also PPD won't be positive. Okay, PPD is nothing but MAN2 test. Okay, and PPD will be positive. That means that person is somewhere sensitized to TB. That doesn't mean he has active TB infection. Okay, so I already told you TB is a form of caseating granuloma. There can be latency. Bacilli can be within the macrophages inside the granuloma for many years, and when immunity decreases, it can come out, okay, as reactivation. So in TB we use DOTS therapy. Okay, we use ATT, that is multi-drug combination, and steroids are used for TB meningitis. Okay, we use Dexa or we use prednisolone. Okay, there are other indications also for steroids in TB. So in TB, which cases of TB we use steroids? Okay, that is important question. One is endobronchial TB. Okay, if the option says endobronchial TB, or if it says miliary TB, okay, or if there is pericardial TB, these three things you should remember. Okay, pericardial TB, and fourth is TB meningitis. These four options you remember. Anything can be asked in the exam. Okay, so let's solve the questions. Which lobe activation is related, cavitation is related to reactivation? So upper lobe. Okay, upper lobe TB occurs means it is reactivation, it is secondary TB. Spread, heterogeneous spread means it is miliary TB. Primary complex is what? Gons focus, that is where the infection has occurred initially, plus hilar lymph node. Okay, hilar lymphadenopathy. Next, dash drives serpentine growth. Actually, there is something called as cord factor. Okay, cord factor is responsible for this serpentine growth of TB. Okay, cord factor is nothing but serpentine factor only. Next, PPD indicates prior sensitization. It doesn't indicate active infection. Okay, if PPD is positive means the person was exposed to TB. He has developed disease or not, we don't know. Okay, but he is exposed. If cold abscess spine, we call it as POTS disease. Okay, so basically TB of spine where cold abscess means there are no active signs of inflammation. Okay, there is no redness, there is no tenderness. Okay, all those things are not there, then it is known as cold abscess. Next, steroids for TB meningitis mainly will give. Okay, and other three conditions also which I have mentioned. Okay, now next we'll go to one Hippel-Lindau disease. Okay, from which many questions are being asked, especially from pathology point of view. So here the problem is with the VHL gene. Okay, VHL gene is on chromosome 3p. Now you know where else this is implicated, in renal cell carcinoma also. Okay, so basically it's a tumor suppressor gene which encodes for HIF. Okay, normally it encodes for HIF, which is nothing but hypoxia inducible factor. Now what happens is VHL actually degrades. Okay, it inhibits HIF. Okay, HIF causes angiogenesis and all. Okay, it is hypoxia inducible factor. Okay, so VHL normally degrades, but if there is VHL mutation, okay, by loss on 3p chromosome, something happens here, then there is HIF increase. Okay, and this HIF increase is in reason for all this clinical manifestations which occur. Okay, so VHL is a type of autosomal dominant disorder. Okay, so whenever there is damaged VHL, okay, or there is some VHL mutation, there is HIF, hypoxia inducible factor accumulation. Okay, and because of this, what happens in hypoxia? It causes angiogenesis. Okay, so there is increased VEGF, there is angiogenesis. So it is basically a form of vascular tumor. Okay, it gives rise to multiple vascular tumors. So what are the clinical manifestations? These vascular tumors can grow in the brain. Okay, it can cause cerebellar hemangioblastoma, it can cause spinal hemangioblastoma, it can cause retinal angiomas. In renal, it can cause renal cyst, it can cause clear cell renal carcinoma, it can cause pheochromocytoma, and pancreatic cysts also. So basically these are vascular tumors which are grown at various places. Okay, so here you can see mnemonic HIF is high intensity factor, hypoxia related. Okay, and basically it is hypoxia inducible factor. Okay, and then VHL means very high level of vessels. Okay, these are mnemonics to remember. And 3 C's. What are 3 C's? One is cerebellum, one is cysts of kidney, and then it is pancreatic cyst. Okay, now in those people who have this mutation, you'll have to do regular CNS and renal imaging, because you don't know when these angioblastomas or hemangioblastomas will develop. Usually it is seen in young adult onset disease. Okay, and it can be sporadic only. Okay, and you should not miss it on renal cell carcinoma screening. So suppose anyone has renal cell carcinoma, you should also screen for other tumors which can happen in the brain or maybe in the spinal cord. You should search for it. Okay, An important thing is polycythemia can be seen because HIF, hypoxia-inducible factor, whenever it is increased, it stimulates erythropoietin also. Okay, so you should also screen for polycythemia. Okay, polycythemia is a clue for this. Okay, so symptomatic CNS tumors you have to remove, or else it will account to brain bleed. Okay, treat renal cell carcinoma early, and you should do genetic counseling because it is autosomal dominant. Okay, so MCQs can be asked: hemangioblastoma plus RCC, always think of VHL. Vascular syndrome, okay, think of VHL, and for pheochromocytoma also can occur in relation to this VHL. Okay, so basically treatment is removal of these tumors, and then surgical removal is the treatment. Okay, so mechanism is HF accumulation causes increase in VEGF. Okay, VEGF is increased. Inheritance is autosomal dominant. Next, polycythemia from erythropoietin overproduction. Okay, and if cerebellar lesions are seen in young adult, think of VHL. Okay, you have to rule out VHL. Okay, rule out. Okay, next we'll go to Werner syndrome. I think Werner syndrome is a simple topic which doesn't need much this one. Okay, basically you should know that it is a defect in DNA helicase. Okay, Werner WRN helicase defect. Okay, this is the genetic defect. It is autosomal recessive. It is involved with impact DNA repair. Actually, we had seen through Werner syndrome in do you remember? Yes, we had seen in degeneration chapter. Okay, in degenerative diseases chapter. Okay, it causes premature aging. Okay, so there can be short stature, there will be cataract, there will be scleroderma like skin thickening, high diabetes risk, high malignancy risk, early atherosclerosis, and reduced lifespan. Okay, so I think that is itself, everything is covered in this. You can go through it. Next we'll go through xeroderma pigmentosa. So xeroderma pigmentosum, one very important question which has been repeated many times, that is, what is the basic defect in xeroderma pigmentosa? And that is nucleotide excision repair. Okay, so remember NER, nucleotide excision repair is the only defect that you need to remember. Okay, you know it is autosomal recessive. Most of the things which are related to repair defects are autosomal recessive only. And here one more thing is, you can see this, right, thymine dimers. Okay, so these are thymine dimers, and these thymine dimers actually accumulate because of UV damage. Okay, so basically there is UV damage, thymine dimers accumulate, because there is UV damage because of this nucleotide excision repair failure, thymine dimers accumulate. Okay, it's an early childhood onset disease. So basically UV exposure occurs, thymine dimers accumulate, there is repair failure of nucleotide excision repair. Okay, and then these thymine TT dimers, you can see here, they accumulate, they cause some mutations, and this lead to early skin and skin cancer like basal cell carcinoma, squamous cell carcinoma, all this. Okay, so clinical manifestations include severe photosensitivity. Okay, so severe photosensitivity, freckling tumors, and there will be photophobia, keratitis, neurological degeneration, and because of malignancies, survival is severely affected. So hypopigmented freckles, okay, freckles are seen, ocular melanomas are seen, DNA polymerase eta deficiency also occurs in this. Okay, this is a rare INICET fact that you should remember. Okay, next, what is the clinical implication? One is vitamin D monitoring, which should be done because these people don't go to sunlight at all because of this photosensitivity and all. That's a vitamin D monitoring needs to be done. UV should be avoided, and the neurological decline which is there, it is irreversible. So remember that xeroderma pigmentosa is not albinism. Okay, albinism is entirely different, xeroderma pigmentosum is entirely different. Okay, and it is autosomal recessive, and neurological deficiencies will definitely be there. Okay, so you see here sunscreen, which is protective, and jackets, so you are shielded from the sunlight. Okay, so if there is UV sensitivity with early onset cancers, especially skin cancer, think xeroderma pigmentosa. Thymine repair defect, thymine dimer repair defect, xeroderma pigmentosa. Autosomal recessive inheritance also, xeroderma pigmentosa. Other features are extreme photosensitivity, childhood cancer, and excision repair defect. Okay, so you see here NER. Okay, that is nothing but no excision of repair of dimers. Okay, that is how you remember it, NER. Okay, and xeroderma pigmentosa, extreme photosensitivity. That is how you can remember. Okay, and it causes basal cell carcinoma and squamous cell carcinoma. So going through the questions, which dimers accumulate? Thymidine dimers. Okay, so now because of this visual mnemonics, you will never forget these things. You don't have to mug up these things. Inheritance is autosomal recessive. Okay, and dash gene defects are seen. Remember, it is XPA, XPG. Okay, remember like this: XPA, XPG gene defects are seen. I think it is not included here. Okay, it is XPA, XPG. Hypopigmented dash are early sign. Hypopigmented freckles are early sign. So you should do strict dash avoid, strict UV light avoidance, and vitamin D monitoring is required. Dash decline is irreversible. Neurological decline is irreversible. So Zellweger syndrome is a form of syndromic association which basically comes under pediatrics, but there is some pathological correlation also. You can see this in biochemistry also. So what happens is here there is accumulation of only one thing which you should remember: very large chain fatty acid, VLCFA. So increased large chain fatty acids causes all the symptoms. Okay. So basically what happens is there is a mutation in the gene called as PEX gene. Okay, PEX, PEX. So this because of this PEX gene mutation, there are, why this PEX? Because it is linked to perioxysomes. Okay, perioxysomes. So perioxysome. So PEX. Okay, so PEX gene mutation causes defect in the perioxysomes. So there are no perioxysomes. And what are perioxysomes related with? It is their function is to process these very large chain fatty acids. Okay, so what happens, this accumulation of very large chain fatty, you can see now here these fatty acids, very large chain fatty acids accumulate in which organ? It accumulates in the brain, it accumulates in the liver, in the muscle, it accumulates in the eyes, in the ears. Okay, so there are various symptoms which we'll see. Okay, so absent perioxysomes, it is autosomal recessive. Again, all enzyme defects, almost all, are autosomal recessive only. Okay, now what is the presentation? It presents in infancy only, and the most common thing you will see is severe hypotonia. So there will be hypotonia, child won't be moving like limbs and all. Okay, so this comes under differential diagnosis of severe hypotonia, and there will be liver enlargement also. Okay, so hepatomegaly with severe hypotonia, always think of Zellweger syndrome. And in brain there will be some neural crest migration defects. Okay, and then there will be vision and hearing loss because very large chain fatty acids come and accumulate here and they cause disturbances. Okay, there is something called a Zellweger facies also, but I think those images will rarely be kept, but you should know this. Okay, so there can be renal cyst also, and because of peroxisomal oxidation failure. Okay, these are the like basic pathophysiology behind it. So it is sometimes known as cerebro-renal-hepato syndrome. Okay, cerebro-renal cerebro-hepatorenal syndrome. Okay, this Zellweger. Okay, because there is defect in brain also, there is defect in liver also, there is defect in kidney also. Okay, so renal cysts can occur. So clinical, there is only support, there is nothing which much can be done. Only thing is you can advise genetic counseling. Okay, so what else is left? I think I have explained everything. Okay, so whenever you see of neonatal hypotonia along with the hepatomegaly, okay, and there is renal involvement. Okay, so always think about Zellweger syndrome. Okay, which gene mutation? Perioxysomal gene, that is PEX gene mutation. Metabolism increased, VLCFA, very long chain fatty acids. Liver, hepatomegaly is more common. Okay, hepatomegaly. Muscle, what happens? Severe hypotonia in infancy only. Okay, inheritance is autosomal recessive because it is enzyme defect. Okay, rest of the things I think I have covered in the image itself. So last point, which which actually is an anatomy topic. Okay, I think it was published in pathology because of some error, so we have excluded this thing from anatomy. Okay, so things are always related in exam. You don't know what type of questions are being asked. Okay, so basically there are three type of cartilages. One is hyaline cartilage, second is fibrocartilage, and third is elastic cartilage. Okay, this is basic histology. So what happens is hyaline cartilage. This hyaline cartilage are present like actually mainly seen in the location. Okay, the location is very important for your NEET PG point of view. One is in the trachea. Okay, C rings of trachea. You can see here now the C rings of trachea. This is hyaline cartilage. Second is coastal margin of the ribs. I'll just enlarge the image. Okay, see here, coastal margin of the ribs. Okay, this coastal margin, this is hyaline cartilage. And third is articular cartilage of the joints. Okay, that is also hyaline cartilage. So their main function is to absorb shock. Okay, it acts like a cushion. Okay, and in the development model for endochondral ossification also, that is when cartilage to bone it's transformed. No? That time it is this hyaline cartilage is same. So hyaline means homogeneous glassy appearance. Okay, and there is avascular. Okay, this is very important. It is avascular. Okay, and there are lacunae and it is present in joints. And it has endochondral model. Okay, endochondral ossification means from the cartilage bone ossification happens. No, that model, in that model you'll see hyaline cartilage. Okay, So degradation of this hyaline cartilage, especially osteocartilage, you'll see in osteoarthritis, and there's limited repair for this because it is avascular. Okay, that's why. Okay, and nutrition, if you ask me if there is no blood supply, then how does nutrition happen? It is via diffusion. Okay, and very important that this articular cartilage, see this articular cartilage, there is no perichondrium. Okay, perichondrium means it is the outer covering of the cartilage. Okay, perichondrium. Okay, so that's why all the nutrients, whatever is there, it goes through diffusion only. Okay, and there is interstitial growth, that is division from inside to out. Okay, that is the endochondral model of bone ossification. So inside, when you see under microscopy, you will find a type 2 collagen. Okay, so this matrix, that is the backbone, that is the glassy part, is made out of type 2 collagen. Okay, I think we haven't come across type 2 collagen before this. We had come across type 1 and type 3 collagen in keloid and like fibrosis chapter. Okay. And next, ground substance is made up of proteoglycans. Okay, so proteoglycan aggregates and type 2 collagen it is made up of. Okay, and then cells, these are chondrocytes which are accumulated in this lacunae. Okay, so these chondrocytes are within this lacunae. Okay, so this is the perichondrium outside, the outside perichondrium, and you can see that inside the cartilage, there are no blood vessels, it is avascular, and these chondrocytes are arranged in lacuna. Okay, this is the classical feature of hyaline cartilage. Okay, so since there is no vascularity, diffusion is the main source of supply of nutrition. So you can see here, right, lacunae, and within that we'll see this chondrocyte. So whenever this image is given in histology or maybe in pathology also, you should identify this as hyaline cartilage. Okay, so this is the matrix. Okay, matrix and the ground substance which is made up of proteoglycan and type 2 collagen. Okay, it is not type 1 collagen, and there is no perichondrium around the joint. Okay, around the articular cartilage, and this regeneration of hyaline cartilage is less only. That is because there is no vascular supply. Okay, so chondrocytes are arranged within the lacuna. Type 2 collagen is present, and proteoglycans, which forms the matrix and the ground substance, and this cartilage has smooth surface. That's why it is used as shock absorber mainly. Okay, and you should know where all just see this image itself, these 3 points. Okay, these 3 points are the main areas where hyaline cartilage is seen. Okay, so matrix is made of which type of collagen? Type 2 collagen. Vascularity, it is avascular. Okay, it is avascular, so diffusion mainly occurs here. Distribution, which location? One is trachea, the C rings. Second is rib cartilages, costal cartilages, and then third is articular cartilages of the big joints. Articular cartilages. Okay. Next, articular cartilage lacks what? It lacks perichondrium. Very good. Perichondrium. Okay. With this, we end pathology series. Okay, so patho we have ended. I think it almost took us 6 to 6.5 hours to complete total pathology. Anyways, in this 6 hours, it is not big also. You can watch it at 1.5x or 1.2x also, and you can finish it within 5 hours. Okay. Now, what you have gained out of this? You have gained all visual mnemonics. You have gained all visual mnemonics. Okay. You have understood all visual mnemonics. You have gone through all high yield topics. Now, what is left? What I want you to go back and what you should watch is, one is you should solve PYQs, and then you will see that most of the things are taken from PYQs only. And second thing is recent updates. That is because intentionally we had to put out recent updates to avoid some copyright issues. So recent updates column in any of your coaching platform, go back and watch it. And third, we want you to do GTs or subject based test based on pathology after you solve this. Okay, so it will act like a TND. Okay, so this is the discussion part, and that will be the test part. Okay, so all the best, and next we'll be going towards anatomy. Okay, in the coming days I'll be posting video on anatomy, and then we'll be going to PSM, and then we'll be going to ortho. Okay, so by March 31 we'll be completing all 19 subjects. All the best.